Franj ma'am, and Professor Manjari Tripathi, a distinguished neurologist and academician from All India Institute of Medical Sciences. We begin with a lecture where we will be exploring the intricate world of sleep respiratory disorders, both central and obstructive sleep apnea. This session, led by Dr. Christina Franz ma'am, will delve into the theoretical foundation, assessment tools, and non pharmacological treatments, followed by a clinical case discussion. Please join me in welcoming our esteemed speaker, Dr. Christina Franz ma'am.
I can do it. I'll try to do it. Good morning, everyone. So today we are speaking about the sleep breathing disorders. Um, there are a lot of diseases in this group of sleep disorders. There are sleep-related hypoxemia, hypoventilation. There are also isolated symptoms like primary snoring. But today we are focusing on obstructive and central sleep apnea. So just to make it very, very precise from what I said yesterday, I just inserted these two next slides so you have the picture. Here we can see the airflow and the respiratory effort. In, a, in an obstructive event, we have no airflow, but we do have a respiratory effort. This is the main feature that differentiates obstructive from central. In the central one, we still have no airflow, but we have no respiratory effort. And how things looks like. So if we see here, we have an event type. So this is the picture of a normal breathing. This is the airway cross-sectional area, okay? So we see it here in this perspective. And here we see that the flow in these blue arrows, it goes through the airway. So here we have the muscles and the flows go smoothly into the airway. We have this inspiratory flow shape of an obstructed flow. And in the flow analysis, that is something that we are not having in this course, but is something that we do daily on clinical practice, is this flow curve analysis. Okay, so the curve will look like this thing here. So this is the picture of a normal breathing. What happens when I have flow limitation? Just like you asked yesterday, snoring, for example, is a kind of flow limitation. So you see that if we compare with normal breathing, there is a reduced airway cross-sectional area. We have a partially obstructed way. We see a flattening of this curve. And you see that this flow limitation happens here. We see it does not go smoothly. It goes like in square things all the time. So this is when we have flow limitation. Now, when we have an hypopnea, we have even smaller airway cross-sectional, even smaller way for the air to pass through. So you see here, maybe these are the muscles, but we have an increasingly obstructed airway. We have a longer flattening and further reduced flow. And the flow curve will look like this here. In the apnea event per se, we have a reduction in the airflow of 90% of the baseline that lasts at least for 10 seconds. And we have a completely obstructed airway, so the air doesn't pass through. The inspiratory flow shape is minimal. You have no flow here. So this looks like a line. And the event will look like this when we have the flow analysis. So I think this is a very nice picture. You can take photos if you want, because it's very didactic and it explains the whole spectrum of the obstructive apneas compared to a normal breathing. So let's delve deep into OSA. OSA is, here again, you have a normal airway, and then you have the hypopnea, a partially obstructed airway. Then you have a completely airway obstruction here. And that, both of them, they lead to an arousal because of the decrease in good oxygen saturation. So this is kind of something that our body does for maintaining us alive, of course. So obstructive sleep apnea is characterized by repeated frequent episodes of complete or partial airway obstruction during sleep. The diagnostic criteria by the American Academy of Sleep Medicine and the International Classification of Sleep Disorders must have these two, A and B. So in the A, we need the presence of one or more of the following: a complaint by the patient of sleepiness, non-restorative sleep, fatigue, or any other sleep symptom. The patient sometimes wakes with breath holding, gasping, choking. The bed partner usually observes snoring or breathing interruptions or both during sleep. The patient might have a diagnosis of hypertension or mood disorder, cognitive dysfunction, any heart or brain diseases, and type 2 diabetes. And the diagnosis requires a kind of objective examination. The gold standard that we set tomorrow is the polysomnography, but sometimes we don't have the polysomnography, so we can have the portable devices, okay? But again, diagnosis is made by a physician. So here we have the cessation of the airflow for 10 seconds, and we still have movement in the thoracic and abdominal belts. So obstructive sleep apnea is usually terminated by an arousal or is associated of desaturation. We have some rules to score that. So for hypopnea, for example, there must be a snoring during an event. There is an increased respiratory flattening that we can see of the flow sign compared to the baseline breathing. Here we see the snoring, okay? There is a drop in saturation, and this is associated with thoracoabdominal paradox movements during the event, but not during the pre-event breathing. We have two rules to score hypopnea. The first one, the peak excursions drop by 30% of pre-event baseline. And the second one, the duration of the increase, a 3% drop in the signal is more than 10 seconds. We have a 3% oxygen desaturation from pre-event baseline or the event is associated with an arousal. The second rule are the same things, but there is a 4% desaturation of oxygen from pre-event baseline. So these two rules are applied daily on PSG. We also have what we call respiratory effort related arousal. That is not apnea, it's not hypopnea. It has no criteria to be diagnosed as apnea or hypopnea. It's a low feature. So it has no criteria to be scored as apnea or hypopnea, but it leads to an arousal from sleep. The duration needs to last more than 10 seconds, and this is an increasing respiratory effort or flattening of the inspiratory portion of the throat, followed by an arousal. So yesterday, I told you that sometimes in the titration studies, we have a pressure, and remember that I told you that I used to have the lowest ones, and then I saw that this rita was appearing, so I had to increase the pressure. So this is like a tricky thing. We have to look to all these variables all the time. We also have a mixed component of obstructive sleep apnea. That is, we have the both components, obstructive and central ones, with each one lasting at least one normal respiratory breathing cycle. So if we see here, we have no airflow here, but in the thoracic and abdominal valves, we see lack of movement, then a little bit of movement. So this is a feature of the mixed OSA. In the past, I would say about maybe 8 years ago, until 8 years ago, the treatment of apnea was based on this metric here, apnea-hypopnea index. That is, the sum of all events of apnea plus hypopnea per hour of sleep. So we still have this classification. From 0 to 5 is normal, is physiological. From 5 to 15, mild. From 15 to 30, moderate. And 30 on, severe apnea. And in the past, the treatment was guided by this AHI. So if the patient has mild OSA, he would go for myofunctional therapy. If the patient has between mild and moderate, he would go for oral appliance devices. And from mild to severe, he would go to PAP therapy. But this stays in the past because we have other markers now that will guide us to treatment. So we don't have only AHI, and there are not only one OSA biomarker. In fact, the thing is very, very heterogeneous. So we have intermittent hypoxia, like we spoke yesterday, this area here under the curve being the hypoxic burden. So this has been studied for the last 4 or 5 years and has shown to be very, very correlated with the increasing risk factors for other comorbidities together with OSA. We have the sleep fragmentation. Someone here asked me if awakenings and sleep fragmentation could be a biomarker of OSA. Yes, it could. And we also have the change in intrathoracic pressure that in research can be easily measured. Well, not easily, but can be measured. But we know now that we have different phenotypes in apnea, and this makes treatment really a challenge. So we have as biomarkers for for OSA, of course, the AHI, the hypoxic burden, this area under the curve, but other markers such as oxygen desaturation index are so important as well. The time the patient spends desaturating or saturation less than 91% is also important. This could be related to the severity of the disease. And of course, we have many cardiovascular consequences. So all of these are taken into account when treating the patient. Okay, now that you know what is OSA, what are the causes? Of course, we have structural factors. We have anatomy going on here. So this is a normal airway anatomy. So if we see here, we have a retropalatal region and a retroglossal behind the tongue region. And this, we have here the approximate normal airway volume. But if we have, for example, in a patient, an elongated soft palate, this will decrease this airway here. So this patient here can have OSA just because of the soft palate. Here we have, for example, this global pandemic thing that we call obesity or being overweight. The fat, the tongue is also a muscle, and as we gain weight, the tongue also does. So we can have fat accumulation inside these muscle fibers. And we all know better than anyone that a muscle with fat cells becomes very loose. So this tongue will obstruct the airway during sleep. So we will have a shape like this and can be anywhere, okay, in here. We also can have some bone things going on here. Like here, we have different sizes between the nasum and the conium here. And we can have different lengths of all these bones that we have here that can also lead to a shortened mandibular length. So this can be one of the causes of OSA. Yes, anatomy are the main cause, but it's not the only one. So here we see in this MRI, we see here the nose and the space for a normal subject. And in an apneic one, see how this is narrowed? So imagine this subject here, he is standing to make the exam. And imagine when he lays down. So everything, when he goes to sleep, that we have the muscle relaxation. And imagine during the REM sleep stage that we have muscle atonia. So this might obstruct. Here we see the retognathia. So when we have this thing back. So in this case, surgery sometimes helps a lot. Sometimes having a surgery, of course, it will depend on the case, on the age of the patient. But for example, in children, surgery is the first option. In adults, it's not. But sometimes I have some patients that preferred to go through the surgery and use less pressure of the PAP devices and some patients that goes through surgery and lose a lot of weight, like 20 or 30 kg, and they are free from obstructive sleep apnea. And also have patients that go to surgery and try to lose weight and still needs to use the PAP devices. But the good thing is that they use lower pressures, so it's more comfortable and the compliance is longer. And here we see the difference between this hard palate here. You see, this one is not normal, and this one is normal. So this one can be very, very related to OSA. Of course, beyond anatomy, we have the neuromotor tone. So we have all these muscles that control the airway anatomy during sleep. And we can have many of genetic or chromosomal disorders and other neurological disorders that could interfere in the obstructive sleep apnea or even central sleep apnea. For example, if a patient has a stroke in the brainstem, it will develop central sleep apnea. So some cases are denervation, fatigue, chronic inflammation, when we have muscle fiber substitution, so we have an impair in the way these muscles function. Behind anatomy and the muscle function, we might have other factors, such as genetic, hormones, pregnancy, diets, inflammation, vascular, the lung volume, and other new concepts in OSA, like loop gain, that is an engineering term that will represent the controller and the playing game, and the awakening threshold, that is completely different in OSA patients. Other cause is rostral fluid shift. So we have a fluid overload, and it looks just like a bottle when we lay down, and all these fluids will come to the thoracic area and to the neck area and will predispose OSA. So during daytime, because of gravity, these fluids are accumulated in our legs and lower limbs, and during the night it comes to the thoracic and neck areas, predisposing to OSA. So patients with heart failure, hypertension, renal diseases, venous insufficiency are at risk for this rostral fluid shift. And the new thing is that the sedentary lifetime has been a lot discussed nowadays because it also increases the risk for this rostral fluid shift. This is a very sad thing to see. It's an opportunity for us to work. In Brazil, at each 3 persons, 1 has sleep apnea. Here in India, we have more than 8% of males presenting OSA and more than 5% of the population presenting hypersomnolence. In Brazil, 25% of the males and more than 9% of females has OSA. So this is a huge thing and also a huge opportunity for all of us because it's an underestimated and underdiagnosed disease. I also tell my patients that this OSA is like a phantom, a disease that we never know that it's there, and when we know, it's kind of late. So any signs of snoring should be addressed as soon as possible. And what we have here are associated negative effects. So we have for sleep apnea an increased risk of 72% of developing type 2 diabetes, 77% of developing obesity, 30% developing coronary artery disease, 76% developing congestive heart failure, 70% stroke and TIA, and 37% hypertension. So we have all these negative effects related to sleep apnea: heart attack, depression, accidents, obesity, cognition stuff, Alzheimer, diabetes, irregular heartbeat, loss of libido, heart failure, risk, a very increased risk of motor vehicle collisions, erectile dysfunction, hypertension, stroke, and heart attack. What are the symptoms? The symptoms commonly are snoring, gasping, snorting, not breathing, fragmented sleep. They might have sleep maintenance, insomnia. They go to the bathroom a lot. So this patient tells you, oh, I wake up 4 or 5 nights to go to the toilet. Sometimes we have bedwetting, and we can also have night sweats. In the daytime, we have excessive sleepiness, fatigue, morning headaches that goes well by midday, it disappears, memory or concentration issues, mood disturbances, and decreased libido. So, OSA is an obstructive apnea and hypopnea index of 15 or more events per hour, even in the absence of the symptoms. So it's very common that a couple comes to the office and the wife says that the husband snores and doesn't sleep well, chokes, gasps, goes to the toilet for 4, 5, 6 times during the night. But the patient itself will say, no, that's not true. I sleep well. I sleep okay. He doesn't feel anything. He doesn't perceive anything. He has no perception of what's going on. I guess these are the most difficult patients to treat because you have to tell them that something's going on and they just don't believe it because they don't feel it. Okay? I have some patients that comes to the office just to make the wife happy. They say, I have one patient now, and he's very, very young. He's like 30 something. And he said, I don't feel anything, but I want my marriage to last. So you are my last hope of my marriage. And I said, me? I'm just going to show you the way. You are the one who's going to walk in this way. So they are happy now because he's not snoring anymore and he's wearing the PAP device. And as he is very tall and thin, I think his PAP device pressure was about 4.5. That are the lowest ones. So he had no problems in the CPAP adhesion. So he's complying very well with the therapy and his wife is very happy. And I'm happy because I did my job. When the patient comes, I always like to look into the mouth to see this Mallampati classification. I'm sure people here from cardio and respiratory will know this. So we take a simple history, we take a complete sleep history of the patient and the simple upper airway examination. Sometimes we can have quick validated screening tools like the stop bang or something. and we have a look at the objective examination that we have. And we see this Malampari classification. So we classify class 1, 2, 3, or 4. This is important for us physiotherapists because sometimes we need to refer this patient to the ENT. Okay? So if I see something going on like class 2, 3, or 4, I will send this patient to the ENT for examination and treatment. We spoke yesterday about this, and I am sure all of you had a dream about the hypnogram and me speaking about the hypnogram yesterday. So we have all these very, very important variables from the PSG. And now you're going to play a 9-minute video so you can understand it better, and I'll come back. I'll play it from this here.
But first, let's take a closer look at normal breathing. Normal breathing during sleep occurs in a familiar, regular cycle. Its characteristics can be monitored in a sleep clinic. The technician usually attaches various sensors to the body. These help monitor airflow through the upper airway, respiratory effort, audible noise, heart rate, oxygen level in the blood, and electrical activity in the brain. The signals you will see and the sounds you will hear during this presentation are like the ones used to assess your breathing during a sleep study. When you drift off to sleep, most of the muscles in your body relax. However, there are exceptions, such as the diaphragm and, to a lesser extent, the dilator muscles, which control the tongue and soft palate. The diaphragm is assisting our simulated model to breathe normally. The dilator muscles, too, are at work, holding the upper airway fully open. As air flows freely and evenly into and out of the lungs, a typical bell-shaped curve of the airflow is seen. The air flows because of the bellows effect of the diaphragm muscle, which sucks air into the lungs. The respiratory bands attached to the chest and abdomen are measuring the effort required to breathe. They produce two traces, which rise and fall along with the airflow trace. Notice how the airflow and breathing effort traces move in sync. You can actually hear these correspond to the sounds of our model breathing in and breathing out normally. When you are sleeping normally, your heart rate is stable, the oxygen level in your blood remains high, keeping up a normal supply to all your organs. As this EEG trace shows, brainwave activity is as it should be during normal sleep. Normal breathing provides adequate oxygen supply so that all the organs can function effectively. You move naturally through the different stages of sleep and get a good night's sleep. You awake refreshed in the morning and are more likely to remain energetic during the day. Flow limitation. What is really happening? For those who have SDV, the muscles in the upper airway begin to relax during sleep, and the tongue and soft palate move closer to the back of the airway. This usually occurs if you are lying on your back or side due to the force of gravity. As the airway gradually narrows, it limits the rate at which air can pass through. We call this flow limitation. The airflow curve now has a characteristic chair-like shape. The middle of the curve looks flatter than it does for normal breathing. The flow at this point is being limited by the restricted airway. As these breathing effort traces show, our model is working harder to breathe. Despite the flow limitation, the sounds of breathing are still fairly normal. From breath to breath, as flow limitation continues, the oxygen level in the blood remains quite steady and the heart rate remains fairly stable. At some point, the increased work of breathing against flow limitation may lead to an arousal. An arousal is a disturbance in the sleep cycle. This may be accompanied by some movement. There is a visible increase in brainwave activity and heart rate. Each arousal has a powerful effect on your body. On arousal, our model quickly takes a few deep breaths. As muscle tone returns to the tongue and soft palate, the airway opens. The airflow trace returns to the normal bell shape, although an amplified one. This flow limitation arousal sequence may occur several times every hour. Although there may not be much change in the sounds of your breathing, your partner may notice you tossing and turning restlessly. You may wake up feeling tired. The effect on your body is strong enough to disturb your sleep and prevent you from getting the real rest you need in order to be healthy. Flow limitation with snoring. What is really happening? In many people with SDB, snoring may occur along with flow limitation. As the muscles in the upper airway relax, the soft tissue begins to vibrate when you breathe. This creates the audible sound of snoring. The tendency to snore increases when you sleep on your back. It is also affected by other factors, such as taking certain medication like sedatives, consuming alcohol, or general tiredness. Notice the turbulence on the airflow curve. Breath by breath, the frequency of the upper airway vibration increases along with the loudness of the snoring. Snoring also increases the effort required to breathe. And it can be rather noisy. Flow limitation with snoring often leads to arousal. Once again, we see why such disturbance during sleep is a matter of concern. It has a significant, visible, and measurable impact on your heart rate and brainwave activity. On arousal, our model rapidly takes a few deep breaths. As he does so, the various characteristics begin to normalize again. Whenever an arousal occurs to restore normal breathing, it interrupts your sleep. Because of the noise that accompanies snoring, most partners can readily identify this type of sleep-disordered breathing. Apnea. What is really happening? When the airflow drops to below 50% of normal, this is known as an hypopnea. If you have SDB, the amount of flow limitation you experience, with or without snoring, varies continuously during the night. As the muscles in the upper airway start to relax, the suction effect of each inward breath tends to draw the soft tissues down towards the back of the airway. Over a series of breaths, the airway progressively narrows and the airflow decreases. There are times when airflow stops completely because the airway is blocked. This is known as an apnea. Air supply to the lungs is interrupted during an apnea. Our model shows obvious signs of an apnea event. The airflow trace changes to a horizontal line for the length of time that the apnea persists. This demonstrates that there is absolutely no airflow, as our model struggles to get air through the collapsed airway. There is no noise at all, which is a particularly dramatic change if the apnea follows snoring. Our model has stopped breathing. An apnea can continue for 10 seconds or more, and in severe cases, for up to a minute or longer. During this time, the heart rate drops significantly. So does the level of oxygen in the blood, since no fresh air enters the lungs to replenish the depleting oxygen. The brain soon realizes that the body is struggling. That is why an apnea always triggers a strong arousal, with severe effects on the body. Our model gasps for air, causing a sudden movement in the nostrils. Brain activity increases significantly. The heart rate after arousal is almost double what it was during the apnea. Our model's rapid breathing increases the airflow and the blood oxygen level begins to rise again. The tongue and soft palate quickly return to their normal position as the airway opens fully. The airflow curve returns to the normal bell shape. With every arousal, your body may move to another position in the bed, but you will probably not remember waking up, even if arousals occur hundreds of times each night. Your partner is likely to notice your apneas and arousals, mainly because, together with snoring, they are keeping him or her awake. Apnea arousal cycles produce significant stresses to your body. But first, let's take a closer look at normal breathing. Normal breathing during sleep
I have edited these by myself. So here you just saw. I like this video because I think it's very easy to understand what's going on. So now that you see it, yeah. Okay, here we go. So what kind of treatments physiotherapists can explore? So the objectives are to promote proper ventilation during sleep. So we need to abolish these apnea events. We also want to promote good sleep habits. So we do that through education. We need to resolve main complaint in other related symptoms. Ensure good efficacy and good adherence to the treatment, and eliminate any possible adverse effects that are related to PAP therapy. So in how we do that? We do that through all these things here. So lifestyle, we are going to go through each one of these right now. So the first thing, lifestyle measures. We know that patient education is a strong recommendation from the AASM, American Academy of Sleep Medicine. So educational intervention should be given to patients prior to treatment. They must understand what's going on prior to engage treatment. And this can be done in many ways. We can just talk about it with them. We can show a very brief video. There are many of them in the internet. It doesn't need to be complete like this one that you saw, but I show a short 1-minute video to my patients so they understand what's going on. So patients should be informed about the disease, the treatment, and the consequences in short and long time. We know that besides patient education, we need to talk about them about weight reduction, dieting, and sometimes refer them to the nutritionist and having exercises as per recommendations. So here we have a very old case report that was published in Chest. It was from one patient that had OSA, and his weight fluctuated within a range of 26 kg. Because of these fluctuations, the HI, the apnea-hypopnea index, also varied when he was at increased weight. So here is to show that body weight is, yes, related to OSA, but not only. As you saw, we have other causes also. And sometimes patients losing weight, they won't be free of OSA. They will still have it. Other thing that we have is what we call positional therapy. We have many devices like positional sleeping systems. So you see the size of these pillows. They are like pillows and body-sized pillows. We have night balance, that is a device that every time the patient turns to supine, it will do like a vibrating zzz, zzz, and the patient will turn around again. This GDS is the same thing, but it's wear as a necklace. So every time the patient goes to supine position, it vibrates. The thing is that the patient will wake. Okay, so we still have one of the things that we want to manage, that is sleep fragmentation. We also have this one, is a new one that is you stick it here and it also vibrates. We have the belts, and like this backpack that you can wear, or these belts that will not make possible for you to be in supine position. Okay, beautiful slide, but doesn't work in practice. I have a very few patients that like to wear these things. And we don't know if just wearing these things for a patient that, for example, has positional obstructive sleep apnea, we don't know if this will really help in long term, okay? In Brazil, we talk about this tennis ball thing, and we, in the past, 20 years ago, we used to say to the patients to sew it in the back so they would not turn. So a cheap measure. Yeah, we don't know if they really work. But here you can see a hypnogram and a result sheet from positional therapy. And what you see here you see the OSA, yeah, OSA, but you see that the events only happen when the patient is on supine position. So here, supine. So this is how supine, this is how positional obstructive sleep apnea looks like. We call it POSA, P-O-S-A. And when this same patient here went to wearing one of those backpack designs that I just showed you, you see that he slept on the right all night long. So we see here the right, and had no apneas. Obstructive ones here and hypopneas here. And you see that the hypnogram went through smoothly. So this is just an example. Now let's talk about the golden standard therapy for OSA and central sleep apnea, that is the PAP device. And PAP stands for positive airway therapy. So here we have, like you saw in the video, what the PAP will make. The PAP is a positive pressure that will make the airway completely open, okay? Because it will open the tongue and the soft palate and will push the tongue anteriorly and the soft palate and here all the muscles. So we say that it will create a column that the air can pass through. So here is just a figure showing what you saw in the video, an obstructive event. And here we have a mask that comes through the nose and the mouth. We are going to talk about this just right now. But you see how the air passes, makes this column, so it's possible to breathe and to relax the muscles at the same time. So it's possible to breathe and sleep at the same time. I usually say to my patients, you have a disease that you are not able to do two very important things at the same time: sleep and breathe. So you do one or another. Okay. And what are the types of PAP devices? If we have this CPAP that is continuous, we have the APAP that is an automatic one, and we have these B-level devices that we don't call BPAP any longer because BPAP is related to a brand specifically, so we call them B-level. And we have these VAPs and the auto B-level and the servo ventilation. Okay, these two. Okay, we're talking about them right. So here we see that the CPAP, the continuous PAP, and the APAP, the automatic PAP, will maintain the upper airway open. The CPAP, the pressure is fixed or automatically adjusted. So it looks like this. When APAP, the pressure increases and decreases just like the patient needs. The B-level and the servo will support breathing in lung disease and respiratory insufficiency. And the servo will stabilize breathing. So these two will breathe with the patient and together and for the patient. These two will only maintain the upper airway open, and the patient will breathe by itself. It's very important for the physiotherapists to know the knowledge, to have the knowledge of the device and all the accessories to explain that to the patient. Of course, this will take some time. Does anyone here already works with the PAP devices? Just you. Anyone else? Okay. So it's very important to know the devices and to know the apps. You have to be very familiarized with the equipment, how to clean it, and how to use, and how often to change the accessories. And sometimes patients ask for different contexts. For example, traveling. How do I travel with my PAP device? How do I go out on camping? with my PEP device? How can I wear my PEP device if I don't have electricity? So things like that, and we need to have an answer for all of that. So what factors can affect the pressure? Of course, anatomical factors, the body mass index. So remember the image of the tongue that I showed you. Alcohol will affect, because alcohol will induce sleep very quickly, but it will fragment a lot the sleep, and the patient will have lack of REM sleep while ingesting REM sleep stage, while drinking alcohol. PAP can also be related to nasal allergies, okay? Sleep body position will also affect pressure, as we talked, supine position is the worst. But also, mask when incorrectly fitted, we have leak, we may have lots of leak, worn out, not cleaned properly. Medications can also affect, and the rostral food chip that we just talked about. Regarding the anatomical factors, we can have many of them. So that is why having a ENT is so important for all of us. In PAP treatment, if the pressure is too low, the patient may snore, also have high blood pressure, hypoxemia. We may have residual events here, so they are not going to be solved. We are going to have some EHI. The patient will still be tired, and if the pressure is too high, they will have discomfort, lots of mask leak. They might have fluid in the ears, something that is annoying. They might have throat burning, mouth dryness. This is very, very common. Okay. And what do we do in practice? Sometimes patients do not tolerate the PAP device. So we have to do a gradual therapy exposure. And how this happens? Here I have a step by step, but you just go one step at a time, and you first educate your patient, explain to them what's going on. Then you show the mask, you show the device. I like them to try the device working without the mask. Then I put them in front of a big mirror that I have, and they will try the mask. Take it off, take it on, and see how it works. Because I think having this opportunity, they will not be afraid of it. So they will manage the mask. And then, after about 10 or 15 minutes that they are understanding the whole thing, they put the mask on and I turn on the device. And they will feel it, okay? I always start with the lowest pressure, but I have friends that start with a highest pressure like 10 or 8. So the patients who wearing it while awake. Sometimes I have to ask this for 1 week, and then they'll come back to the office and we try to wear it for 1 hour during sleep. So it's a very step-by-step things until the patient can completely wear it during all night long. But what is the effect of CPAP on the patency of the upper airway? We know now from a Brazilian group that the route of delivering the pressure is very, very important. So we know that the nasal route is the best one. So we should this is guideline, okay? So we should start PAP with the nasal route. And we know that coming through the nasal, there will be a pressure column here that will push the soft palate against the tongue and will increase this area. What we know from the oronasal route, when the pressure comes into the nose and the mouth is that it can counteract the effect of the pressure column by increasing this pressure transmission, and so you can push the tongue behind. So here we might worsen the problem. So this is the reasonable explanation why we need to start with the nasal route. In Brazil, oral nasal masks are very, very common, just like US. So sometimes patients come and they ask, I want the biggest mask that you have. And I say, no way, we are going to start with the smallest one. And if needed, we can go to the oral nasal ones. So I have patients in both masks because it's a very nice thing to speak about, but sometimes patients just can't close the mouth while sleeping. But I do try very hard. First the nose, and this is my last option, but still an option. So in the material that I got for you, I have this clinical decision making for PAP devices mask selection. This is from a friend of mine. I was in the examination for her PhD, so this is her PhD. And if we have a patient for PAP treatment, we have to see the sign and symptoms of nasal disorders. And if there are symptoms, ENT will look for that. And if the symptoms are not improved, we can see and might consider a nasal mask. Otherwise, we go to a nasal mask. So this is a very nice research for you to read. But always remember that the preference is always the nasal route, okay? And all the nasal symptoms should be treated before we start the PAP therapy. So we have many kinds of nasal and oral nasal and oral masks. So this one has a triangular shape. This one just goes like a pillow. And we also have the intranasal, like a cannula. This other one is bigger. It comes into the nose and the mouth. And for some patients, and I have to tell you that I have no patients wearing this one, but we had once a case at the university that the patient had a huge problem during because of trauma in his nose. So he was able just to breathe to mouth, so we needed to use just an oral one. So treatment is very individualized. Each patient has a different treatment. So here are some examples of the brands that and the types of the masks that we have in Brazil. So this is the pillow one, oral nasal. These are the intranasal, another type of oral nasal with something coming to here. Okay, these are the ones that are very liked in Brazil because they have the tube up. So the tube, it's not here, okay? It's here, so it's easier for patients to move. And I think they are more comfortable. But sometimes patients prefer these ones here. So it's not me that choose the mask. The patient will do it. I don't sell anything in my office. I refer them to sell wherever they want to buy all these things. But I make them try at least 2 or 3, and they choose which one they prefer. They go home, they try it at home, and if they don't like it for 2 or 3 days, they come back and we change it again until they feel comfortable. Because I think the first very important thing they need is to feel comfortable to wear that. So we have these nasal pillow, the cradle, the oronasal, and a lot of minimal contact masks. Now we have oronasal and nasal ones that are really, really small. Okay, so some advantages of them is that they have small area of contact. Some patients with claustrophobia can wear them. They better looking, maybe more comfortable. And the oral nasal has the advantage that patients with mouth leak will wear it. But as I said, this is my last option. I do everything that I can. I'm going to show you the things that I do. Well, we also have some apps that will scan the face of the patient. And this is a patient in his phone scanning his face, the multiple points of his face. And this is called mask selector. And then the device will say the suggested mask and the size, and the first one, the second one, and the third one, if the patient doesn't like this one. So we got all these things. To tell you the truth, I hardly wear this, but sometimes patients love these technological things, and it's possible for us. I think I've used this less than 10 times, but okay. We also have, and I encourage you all to read this practice guideline from the American Academy of Sleep Medicine. So this is a must-read article, and they have a conditional recommendation that is that behavioral, as we said, and troubleshooting interventions should be given to patients at the initial period of fatigue. As you are going to see just right now, there are many clinical side effects of fatigue. We have those related to the mask, related to the pressure, and others. So here are a collection of pictures of me and my patients trying to wear these masks. Here I have some videos that I recorded for patients in order to try to make the mouth closed during sleep. So we can just put some tiny straps. We have many straps that can be used, and they are very hygienic, and you use once and throw out, and it doesn't hurt the skin. So it's a way to make the mouth closed, because you inform the muscles here a new proprioception of things. Sometimes it works, but sometimes patients put that two stripes here, and then the middle stays like. And then I say cross the stripes, and then here goes like. And sometimes they get like this, pushing all the mouth. Everything we tried not to go to an oral nasal one. So this is a patient that was wearing an oral nasal mask, but he had lots of leak. But he loved to sleep in prone position. And the mask was, the pillow was always taking off the mask. No, we are still struggling with the leak with this patient. He didn't like it. He hated it. So sometimes he's a dementia patient, and when we wear the hook, he was taking it off. So we had to put a huge mask very tight to the head so he wouldn't remove it. So here is a female patient, and you see this is the intranasal mask. But if you see here, it's incorrectly placed, so there is leaking a lot. Okay. This is an under the nose mask. And what the patient did, he opened it and stuck his nose into that. So completely wrong position. You see here is lateral. So all these things happen all the time. Here we were using, I forgot the name of this thing, to make chin strap. We were using a chin strap because it's another thing that we can use, trying not to have mouth leak. But the patient tired it so much that you see the cheeks are all like these, and he started developing headaches. So all these things happen daily. This guy here was bracing and having it every time, so that the teeth was hurting him. So lots of different things happens. This is very old patient of mine. I'm sorry, this is in Portuguese, but this patient came many times to the office, and we were trying her to remember how to put the mask on. So I said to her, okay, give me your cell phone. I will take pictures of each step and you will take home. And then here preparing assembling the mask, and then positioning it, putting it on the head, starting from the nose, having the place here, adjusting it, fitting it closely but comfortably, and then ready, good night. So I had it printed for her, and she was looking, and then we got this thing resolved. So you see, sometimes with very, very simple things, we can help them. Here are other clinical side effects related to skin irritation and lesions. So these can happen mainly when they or have allergies or tied up very too much. And then we can wear some straps that we have. We also have silicone ones in the market. Okay. So we try everything. We have many pressure-related side effects from the nose, like rhinorrhea, congestion, resistance, pressure intolerance. We have many related to mouth, just like I showed you this one. Sometimes the patients, they complain of, even in the morning, they say something is not going on just because they started the bath. So we decrease the pressure a lot, wait, see if this gets better, otherwise ask for physician help. We have to be very, very careful with face growth. Okay, so in children, we might need to use 2 masks to change it every time. In the eyes, we might have dryness or floppy eyelid. And in the ears, we might have pain or even increased pressure. So, as you see, we have many of these negative effects of the PAP device. This is another paper that I strongly encourage you all to read. This is the Brazilian consensus again. And we have a step-by-step for the follow-up of these patients. So I know this is too small, but you have this in the materials, okay, that you are going to have at the end. So you can have a look into this. And what this says is that we have set some criterion. So we set 7 criterions. If the patient fulfills the first criterion, then it goes to the second one. So it's not a protocol like you stay 1 month in step 1, then 1 month in step 2. It goes according to the patient. Okay, some patients will stay 1 week in the first step, but others might stay 1 year. So it depends how patient tolerates, and depends how is the compliance with the PAP devices. One of the interesting things that we have nowadays is this telemonitoring. So the patient uses the devices, and in the morning I can see all the variables in my computer. So I can give him a call and say, let's adjust the mask because I saw lots of leakage in this night. Or sometimes I give a call to my patients and say, what's going on? It's been a week that you don't wear the PAP device. And they go like, oh my God, how do you say, okay, I'm wearing it tonight? So it's something that you need to be very closer to the patient so they can see the difference that having a good night's sleep will make on their lives. Talking about adherence, we have this more than 4 hours per night of use of the PAP device as being the recommendation. And the duration of the use has to be more than 70% of the period. But this is what everyone says, but it really came from the US medical system. So my patients always ask, how much time I need to use this PAP device? Do I need to use it every night? And my answer, of course, you already know, is yes, all the nights for 100% of the time. But we have some, I usually even say to my patients that they need to wear the PAP device during the naps, okay? Because we already know that we have a dose response for the using the CPAP and the functioning. So it's very, very important that they use it. But we have some different outcomes in literature showing that for excessive daytime sleepiness, when seen in a subjective manner, it can be more than 4 hours per night, but when seen in an objective manner, it has to be about 6 to 7.5 hours a night. So it depends on the outcome that you want. For memory, for example, the PAP needs to be used for more than 6 hours a night. And for cardiovascular mortality, it needs to be used for more than 6 hours a night. And for hypertension pressures, it needs to be used for more than 6.6 hours a night. Otherwise, it won't decrease the blood pressure during the night. So we have different outcomes and different hours according to these outcomes. Well, just for you to know that these exists, but of course, in Brazil, myofunctional therapy is for speech therapies. So we even have some exercise that you can make on your cell phone. So myofunctional therapy, according to this literature review from Cochrane Library, it improves a lot in some patients. So we need to know what kind of patients we are sending to the speech therapies for myofunctional therapy. So it's a set of exercise that needs to be made every day, maybe 2 or 3 times a day, and can decrease the intensity of the USA symptoms and daytime sleepiness, and can be performed only myofunctional therapy or combined with PAP therapies. I think it's in children, they didn't have uh, such good outcomes because compared to nasal washing alone, adding myofunctional therapy resulted in little or no difference. So myofunctional therapy is usually used in adult patients. I asked someone, I just don't remember who it was now, about the Professor Magini. I asked him about the dentists here in Delhi, because in Brazil, another thing that is very common, and we work together a lot with the dentists, is that some patients can wear these intraoral devices. So this is a device that they put for sleep and take it off when wake up. And the idea is the same, but the mechanism that it treats obstructive sleep apnea is different. So it pulls this forward, and we have the space for breathing. So sometimes patients just don't tolerate the PAP device, and then we ask for help for the colleagues, dentists colleagues, to see if they can wear it. But of course, they have evaluation, they have a lot of objective examinations like TC to see if the joint here can be pushed with this intraoral device. So you must know that this is an option. We also have this thing that, to tell you the truth, I never saw a patient wear these. These are devices that protrude the tongue. Very, very annoying. I couldn't wear this. I even never tried them, but some dentists in Brazil prescribe them. We have a group in Rio de Janeiro that are doing a lot of research in respiratory muscle training. So if any of you wants to do research in this area, I can put you in contact with them. They are a very nice group of research, and they are having good experience having this muscle training with these mild and moderate OSA patients. Okay, this is from Torres Castro from Chile, a group in Chile that also studies this. And this consists of training the surrounding collateral respiratory muscles. So sometimes it helps a lot alone, and sometimes it needs to be combined with PAP devices. Of course, as we have said before earlier today, exercise and weight loss is a must. So I strongly encourage all my patients to exercise daily so we can have impact on apnea, sleepiness, and increase the sleep quality of these patients. Other things that are going on that I think you must know is that we also use the TENS. You see, physiotherapy and TENS are all together. And we also use the TENS as external stimulation here in the skin for hypoglossus and genioglossus stimulation. And also we have this device that will deliver these stimuli into the tongue. But the thing is that sometimes you strain the whole tongue and you get worse apnea. So this is not something that physiotherapists do in Brazil. It's related more to the speech, this one here, speech therapists. So these are new things that are coming on, and a lot of research are still needed for us to use in daily practice. Okay? So let's talk now about central sleep apnea. It's going to be shorter, but also very, very important. So just let me have yeah. No, I don't assess for that. I send them to the ENT. So you see, we are always working together, other healthcare practitioners. So it's great because you learn from them. Okay? So, central sleep apnea is characterized by a temporary loss of the production of respiratory stimuli from the pacemaker in the pontomedullary region of the central nervous system. There is an absence of central stimuli that will result in loss of movements in the main ventilatory muscles, the diaphragm, the thorax, and the abdomen. So we see here a cessation of the flow that's usually more than 10 seconds, and it is without thoracic and abdominal effort. Can be terminated by an arousal or associated with a desaturation. There is no snoring during the event. There is no increased respiratory flattening of the flow sign compared to baseline, and there is no paradoxical movement during the central event. So this is a disturbance in ventilatory control. This can be a disturbance of the central controller, here explained in this picture, or the effectors, the muscles, or even in the sensors. So it can be a combination of them. So here is how things get harder, because it can be a combination of them. Usually, we start treating the patients, and later we will have a cue of which one of these components are involved. So here we see some polysomnographic patterns of central sleep apnea. What we see here is what we call the Chine-Stokes breathing, that is very, very common in patients with heart failure. So we have an instability in this ventilatory control. We have this increase and decrease pattern that we call crescendo-decrescendo pattern. Okay? And here we have the apneas. So this goes on and on and on. It's a pattern through the night. Here we also might have in stroke or in drug-induced patients, we also might have this instability in the control of the ventilation, leading to a central sleep apnea. So I want you to remember that central sleep apnea is related to any comorbidity. So have a look for your patient for heart failure, stroke, pulmonary hypertension, chronic renal failure, chronic opioid use, or OSA. It can happen together, as we saw. So some clinical characteristics of patients with sleep apnea, they can demonstrate daytime sleepiness, morning headaches. Sometimes it's combined with OSA, and then can snore. They might have any kind of respiratory failure. They might have poor pulmonary or polycythemia. And when they are combined with obstructive, they might present all the obstructive symptoms. They might also have insomnia and awakenings and things like that. So we have four main kinds of central sleep apnea. The chain-stop breathing pattern that I just showed you, a drug-induced one that is mainly induced by opioids, the one that we spoke yesterday, I'm sure you remember, the treatment emergent central sleep apnea, and idiopathic one. So this is the crescendo pattern of the chain-stop breathing. Here we have the apnea. Here we see the lack of thoracic effort, and here the lack of thoracic abdominal effort. So here is how it looks like in a window, in a PSG window. And we also have this automatic tracking of the central apnea. So the software will show us where this is happening. Here we have a split night polysomnography result sheet, and we see that in this first diagnostic part of the polysomnography, there were no baseline central apneas present. And then when we start the PAP device, the central apneas start to present. So this is typical of treatment emergent central sleep apnea. Sometimes we have this idiopathic one. So this is an example of a 27-year-old boy, non-obese, that presented with mild daytime sleepiness, nocturnal awakenings, and unrefreshed sleep. So what we can see here is in the airflow, we see that it stops many times, and that we have the lack of effort on the belt, chest, on the belt here. This one is the thoracic belt here, okay? And we also have these saturations all the time, marked in these blue squares. So what is the treatment for them? This is a disease that we need a physician to get at. We treat the underlying disease, we go for PEP therapy, and we have some complementary ones. So just like obstructive sleep apnea, we also have positional therapy for central sleep apnea. Because of its association with airway instability, and we lack the understanding of this, the complete understanding of the disease. But we know from many studies that the lateral position, see, you sleeping at your side, will attenuate the central sleep apnea, mainly in patients with heart failure. So sometimes we have specific positional central sleep apnea. Okay? The mechanisms are related to reduction of hypoxemia. I have now a clinical case that I combined both, so we can translate and understand everything that we saw until now into practice. So this was a patient of mine, 59 years old. He was a physical educator. I saw him for the first time in June from 2022-21. He was referred to me by his neurologist, and his main complaints were tiredness, fatigue, and excessive daytime sleepiness. He said he had lack of memory and concentration, non-restorative, and fragmented sleep.
He said he had poor sleep quality and he complained a lot of nocturnal spasticity. He had a stroke in 2014 and it showed a ischemic and an hemorrhagic stroke. The stroke happened at 11 o'clock in the night when he was napping. And the NIH severity scale was 20. The modified Rankin scale was moderate to severe disability. And he also presented some signs of Valerian degeneration. He used to work. I remember he worked for about 20 years as a shift worker. He had a congestive heart failure. The ejection fraction of his heart was less than 40%. And he was on medication for hypertension and prostatate hyperplasia. He had a BMI of 24. His neck size was 34.5. The Malampari classification was the second class. He had considerable sleepiness in the Epworth sleepiness scale, and he was an hemiplegic in the left side because of this stroke. He had no routine, and his sleeping time was, he went to bed about 1:30 in the night or 2 in the night. He said he didn't take long to sleep. Usually woke up at 8 a.m. but stayed 2 more hours trying to sleep a little bit more. He had lunch about 4:30 p.m., which is in Brazil like evening tea. We usually have lunch at midday in Brazil, and lunch is the main meal. Okay, it's the most important meal. So, and he took a nap after his lunch for about 2 hours or more. So by now, I know you're all thinking about many things that already can be treated and discussed with this patient. And he usually got his dinner for 11 in the evening. He said he had to hurry to the toilet during the night for 2 or 3 times, and he was on many medications like this for all his diseases. But as he was a physical educator, he knew the importance of exercising, and he exercised daily, going to Pilates and academy. He was also into the neurological rehabilitation. His wife was a neurological PT, and he also was into speech therapy because of the sleep. And right after the stroke, he had some sessions of psychotherapy, but he was at that time not going to that. So the patient came to me with a PSG, and what we saw is that he had many arousals. So the arousal index was about 28 number of events per hour. He had a moderate OSA, 26 events per hour, being 17.9 of obstructive ones, 6.7 events of hypopnea, and 1.4 of central. So he didn't have any central sleep apneas, only obstructive ones. But he had a very important desaturation. The nadir of the saturation was 68%. And he spent about 45 minutes of the night below 90% threshold. We start then the home titration with the automatic PAP, and the physician asked me to put him between 4 and 10 centimeters of water. The initial pressure was 4. We used no pressure relief, but we used the ramp for 20 minutes. And these are his first days. So what we can see here is the pressure. He was on medium 5.8 and he had a maximum of 10.2. He had some very punctual specific leak here, as we can see, but mainly of the time the leak was within average. But the respiratory events decreased only from beginning to now, only for a half. What I saw, remember the central apnea that was 1.4, now was 6.1. Here we have in green the days that the patient used more than 4 hours, and in red the days he used less than 4 hours. So his dotted line here is to mark the 4 hours. When I opened his flow curve analysis, I saw the GIAN stokes breathing, this crescendo and decrescendo pattern all over the night. So this was what got my attention. He was having like 31, 40 minutes or 40 seconds of sleep apnea, even on PAP device. But the first thing that was very, very hard with this patient was choosing the mask. So the first thing we tried the nasal route. There's no sound. There's no sound. So this is the patient trying to put the mask on. And this one he chose because it was easy for him to use just one arm. And this one has a little hole in the here, as you can see. See here, the little hole. So he was able to feel it and adjust it by himself because he didn't want to depend of his wife. And he was looking for functional independence. So why titration this patient? He had some difficulties at the first days. It's normal. He had a little bit of phobia of the thing. But we talked so much and we had some 5 or 6 sessions about education. Then he had a fear not to wear it and have another stroke after we talked. So he started wearing it. And he was one of the most compliant patients that I had. His wife, he hated to be dependent on his wife, and with the PAP, he improved it over the time. So as you see here, this is a very long history, and we've been together for so long. But as you see here, the EHI wasn't getting much better. After the titration, I fixed the pressure in 5.8. I discussed that with his physician. But what we saw here was that central index of the apneas, you see, it was 1.4, went to 6.1, and then was increasing to 12.8. So this is typically treatment emergent central apnea in a stroke patient. The GIAN stoke breathing also increased a lot. So we discussed it again with the physician, and as nothing was getting better, it was remaining the same thing, and the months were passing by, we thought to perform a high-resolution pulse oximetry, and we saw that saturation was 89%. Yet he was feeling better, he has no daytime sleepiness, he diminished, he reduced his afternoon nap. The cardiologist changed the medication, reduced the medication, and we went to fixed pressure on PAP. Yet, when we reached the month 5, it didn't get better. In fact, it got worse. So I had to reduce the pressure, but it was worsening all the time. As you can see here, the chain stop breathing was increasing, alarmingly increasing. So again, I talked to the physician. The physician asked me to increase the pressure and wait for 2 months as he was going to change medication. We did that and nothing happened again. So the patient was basically at the same central apnea going on month 8 of treatment. So we talked about, and the physician, the cardiologist, started many investigations. And what we saw is that he was on heart ejection fraction that less than 35%. And this was the thing that was contributing to worsening of the symptoms and increasing of the central events, all at the same time. So I had the brilliant idea to ask the physician to have a split night study and with the PAP. So what I wanted here was to see if the PAP was working or not. So I asked the physician and the lab technician to make the first part baseline with no PAP and the second part of the exam with the PAP, with his PAP, with the pressure that he was using. And we saw that there were no changes in the breathing pattern with the PAP device, with the pressure that we were using. So we sat together, 4 of us, me, the cardiologist, the neurologist, and the patient. We discussed what was going on. And then the cardiologist decided to start this medication that is for central sleep apnea. And he started it in very low doses. And then we were able, you see, the EHI finally was 2 and the central index 1, 0.1. But he was using PAP device. So this is an example of how we work together, and the work is not only from the physiotherapists. We have to be together with all health practitioners on behalf of our patients. Here is, I just brought this because I think it's very interesting. This is the biphasic sleep that this patient has. So each one of these lines here is representing 1 day. And we see that the patient has nighttime sleep here and afternoon sleep here. So this patient has 2 periods of sleep. So approach as now obstructive apnea was resolved. Treatment emergent central sleep apnea was resolved. We were looking to resolve this sleep. So I want him to sleep for just 1 period of night. So you see, this is a patient that is with me for about 5 years, and we still have a lot to do. So I have many reading materials on this disease for you all, and I'm happy I finished on time. Thank you very much for being here.
I
haven't actually gone for?
Have you got glasses?
Sorry,
To
I
check
didn't
the
hear.
carbon dioxide and the
No, we
baseline of the
haven't.
sat-
No, we
particle.
haven't. Yeah, no, we haven't. You see, I come from neurology background, so this cardiology. If you were here, maybe you would ask the physician to do that. But it's a great idea. Thank you for your input.
So, why I'm saying like this, because what I feel in that particular patient, the fall of the saturation or the partial pressure of oxygen was constantly being low for a long period of time. And when we were providing with the high positive pressure, it was actually correcting the hypoxia, and the patient was on hypoxic, right? That could be the reason for the central apnea.
Yeah, but see, here is just a very short period of the treatment of the patient. See, I wasn't able to bring the whole picture, so I brought just some insights of this, and I'm sure we did the right thing because I was together with the neurologist and the cardiologist. So I think that's because of it. You just see a part of it, you don't see the entire thing going on 4 years of treatment. Okay, thank you. Yeah, perfect. Good input. So we have a break now?
Thank you so much, Dr. Christina, for that detailed and thought provoking session on sleep respiratory disorders. The lecture provided us with a very broad framework and improved our understanding of the topic. Please join us for a tea break and take this time to refresh yourselves and get ready for our next session, starting promptly at 11:45 a.m., where we will explore yogic intervention for sleep by Professor Manjari Tripathi Ma'am, a distinguished neurologist and academician at AIMS, New Delhi. Thank you. Please take your coupons with you. Tripathi, a distinguished neurologist and academician, currently serving as the in charge of the Center of Excellence for Epilepsy, a collaborative initiative of the Ministry of Health, Department of Biotechnology, and AIMS. A DM in neurology from the prestigious NIMHANS, Dr. Tripathi has pursued multiple fellowships, including at NIH UCLA. With over 24 years at AIMS, she has mentored numerous students while passionately advancing epilepsy care through community outreach, free treatment initiatives like Ekatvam, and rural epilepsy camps via iReach. Her prolific research includes over 445 publications in leading journals and over 17,000 citations. She pioneered the first Indian series on the autoimmune epilepsy and introduced innovative surgical techniques for epilepsy treatment. Professor Tripathi is the recipient of multiple national and international honors, including the American Association of Physicians of Indian Origin Sleep Researcher Award and the Outstanding Achievement Award in Epilepsy at the Asian and Oceania Epilepsy Congress. She is also a visiting professor at the institutions in Germany, Indonesia, Morocco, and has held key leadership roles in neurological societies. Please join me in welcoming a remarkable Professor Manjari Tripathi. She will be guiding us through a lecture focusing on yogic interventions for sleep problems. Please come, ma'am.
Thank you. At the outset, I'd like to thank the GIAN program and Madam for having me here. My main area is, of work is epilepsy, but my second hat is sleep and particularly sleep and cognition. So today I'll be talking to you because, the topic is such that it is about non-pharmacological interventions. So this being the topic, you people have been introduced to insomnia. Yes? So you broadly know that you could fall into any of the three categories. One is you could be sleep deprived. Okay? Is sleep deprivation the same as insomnia? No. Sleep deprivation means you are not getting an adequate opportunity to sleep. That is sleep deprivation. Okay? So nowadays there are lots of causes of sleep deprivation. Am I correct? We have lots of causes for sleep deprivation. Yes, what are they? Mobiles, Instagram, X, whatever. So that's sleep deprivation, it's not insomnia. Then you have excessive daytime somnolence. That is, you're sitting in this class and you're dozing. So that is another phenomenon, and that has a lot of causes for it. But the majority or the bulk of the symptom is despite getting an adequate opportunity to sleep, okay? You're getting 8 hours to sleep. You're still not sleeping, and that is insomnia. So despite having an adequate opportunity to sleep, you're not getting sleep. And this can occur in two types. One is the house may be on fire and everybody may be fighting, but they'll sleep well. Some people cannot, okay? And then there may be a sudden event which triggers off. And that may keep happening in small amounts, which perpetuates it. Is it clear? So that is why it doesn't happen to everybody, but it happens to a majority of the population. Do you know what the statistics are in India? The statistics in India is about 30% of our population has insomnia. I think it's an underestimate. How many of you know of an insomniac in your own family? In your own family. I think every family has one insomniac. Okay? So if you have a household of 4 people, then one would have insomnia. Now, the treatment of insomnia in our country is go to the pharmacy and take alprazolam, okay? Or go and they'll give it to you also. They'll give you very happily. Over-the-counter medications are so easily available, but are they good? If you get used to alprazolam 0.25 milligram today, tomorrow you want to take 1 milligram, and after 3 years you want to take 2 milligrams, and you just want to go on increasing it, and then you get less and less effect, and you get more and more addicted or used to it. So alprazolam is not to be used, okay? The treatment of choice for insomnia is non-pharmacological, okay? Non-pharmacological is a first-line therapy. The established non-pharmacological therapy is cognitive behavior therapy. Now, who does the cognitive behavior therapy? Psychologist. How many psychologists we have in Delhi doing CBT? Do you know? Very few. Okay? So the number of the psychologists who can do CBT is very few. And do you know the cost of one CBT session? Do you know the cost of one CBT session? Okay? It's like going to a parlor. Okay? So it's 3,000 to 5,000 rupees for each CBT session. Okay? When you go to the parlor, the lady will tell you, this needs a little bit, can I do this? Then she'll say, this needs a little bit, can I do this? And she'll make you spend about 3,000 rupees before you know that you finish that kind of money. So here, CBT is also expensive, okay? But people are trained for it and they deliver it. There are 2 kinds of CBT. One is face-to-face. Like you're sitting in front of me in the room, we make you relax and do CBT. So that's going to be more expensive. And then there is group CBT, where people can sit or lie down in a group and do the CBT. Or there can be distance CBT. During COVID, many of the psychologists started doing online cognitive behavior therapy. So here you really need trained psychologists, you need trained, personnel doing it, and they charge for it. So now it's not new, but in our Indian system, we have a technique of restful sleep or it's not actually sleep, it's just a restful state. And that is known as Yoga Nidra. Okay. Now, or it's also known, the Indian term is Yoga Nidra, but the actual term is meditative sleep. Okay. Now, this is a very old technique. It is coming from ancient times, like even BC. It's before Christ's time that this technique was devised by our sages. And it does not have any religious underpinnings to it. So there is no religious practice that we do in this. It's just a state of relaxation. And what is the beauty? You can do it yourself. You don't need to shell down money for a psychologist. So that is what we at AIMS thought. My PhD student, she said, Madam, why don't we compare Yoga Nidra with cognitive behavior therapy? So we did a randomized control study which was published, where we randomized in a blinded manner patients who received Yoga Nidra versus patients who received CBT. And we saw the outcomes. So as I told you, it's a very ancient technique. And you can see here that the method we follow is that of Satyananda. Okay. And this is just to show you that there are books and volumes written about Yoga Nidra. Before we go to Yoga Nidra, there is a lot of, evidence which is out there of how yoga helps stress, blood glucose, physical, mental health, and autonomic functions. Okay. But there was no study for insomnia. And that is why we started looking at the possibility of doing such a study. Now, I will talk about the study, but my main aim is to demonstrate how it is done. Believe me, once you get used to doing Yoga Nidra, you will be addicted to doing it. You will do it on your own. You will do it when you're exhausted, and you will get up refreshed. So it is such a technique that I am addicted to Yoga Nidra. I do Yoga Nidra whenever I have to, try to do it daily. And the ideal time to do Yoga Nidra is in the morning, empty stomach, not after a heavy meal, because then you'll just doze off. And you don't want to doze off. It's not dozing off. So you would like to do it early morning. Ideal time for me is when I'm trying to get out of bed. That's when I do it, so that when I get out of bed after 20 minutes of doing it, I'm fresh and ready to go. So let's go to the, evidence which is there. As you can see, there are a lot of evidences. And you've heard of sleep hygiene in this 5 days. Sleep hygiene, you must have heard. How many of you have a routine for sleep hygiene? Very good. One hand only. So sleep hygiene is just the awareness that sleep is an activity which also needs to be prepped up for. Okay. Like when you go outside, you prep up. You will comb your hair well. You will, dress up. You will not look shabby. So the same way, when you're going to sleep also, you have to do some prep up. That is sleep hygiene. And so you will avoid tea, coffee after 2 in the afternoon. Okay. So that you're not getting caffeine into your system. You will try to dim the lights in the room where you are, where you're likely to sleep, so that the melatonin gets going. Okay. Then you will not start fighting with your sister or your brother or having an argument with your father, just before bedtime. You'll be cool and calm. You won't read anything frightening or watch a horror movie at that time. You'll probably be relaxing with the very cool or nice book which you're reading, which makes you relax or makes you sleepy. There's a book which makes me sleepy. That's the book of biostatistics. The moment I hold the book at 8 in the night, if I'm not getting, or 9 in the night, if I'm not getting sleep, I just get my biostatistics. Let me see what is confidence interval. And within 15 minutes of trying to understand what is confidence interval, I will be feeling sleepy. So everybody has one such book. Okay, so try to get hold of that book. Then you can have sleep association objects. Okay, like some people have a teddy bear, some people have their mother's chunni, and some people, there are different people hug their mother and the mother's sari and sleep sometimes. Then, of course, you should use the bed only for sleeping. You can't use the bed for working on your laptop, watching your Insta, and looking at your mobile, eating food. Some people Hostel में तो चलता ही है. Hostel में you people eat food on the bed. Okay, that I know because even I've done that. Okay. So don't avoid doing non-sleep activity on the bed. Then of course, don't keep a clock in front of you. These are non-pharmacological. These are very easy. Nothing is a medicine here. It's just behavior. So this is also non-pharmacological management of sleep hygiene. Don't keep a clock and keep staring at that clock right in front of your bed, you know. Otherwise, you'll say, oh, it's now 10:15, I have not slept. Oh, it's now 10:30, I have not slept. Now it's 10:45, I have not slept. And that will induce a sleep anxiety. Okay, you will be in a state of perpetual anxiety. Why you're not sleeping? If you lie down on the bed, what is the normal time you should sleep in? Suppose you've gone, it's 9:30, you've gone to the bed with the intention of sleeping. What's the normal sleep latency for me and you? 15 minutes? Okay, definitely not more than half an hour. So, if you're not sleeping and it's become half an hour, what will you do? You will get up? Okay, no. I mean, you do that, you look at your mobile, that is not going to induce sleep. But as a part of sleep hygiene, you should not look at your mobile at that time. You should get up and you should just sit down and maybe read the most boring book you have in your hand. Okay, and then go back to the bed when you feel sleepy. So don't keep lying on the bed non-sleepy. That will not produce sleep. That will only increase your rumination and sleep anxiety. So this comes under the sleep promoting non-drug strategy. Is it clear? Now sleep restriction. Sleep restriction, how many of you all are aware of it? Non-pharmacological. Sleep restriction means you will go to bed and you will get out of bed. The moment you're feeling sleepy, you will go to bed. The moment you get up, you will get out of bed. You don't just go on lying on the bed in the morning for 1 hour doing this, that and the other. So you use that time, you restrict the time in bed to only the time that you are sleeping. Stimulus control, of course, you all know about. Cognitive behavior therapy, we've talked about. And then we have the yoga, which is Yog Nidra. So, Yog Nidra is resting stillness, and the procedure is usually done for 35 plus minus 20 minutes. Normally, it's around 20 minutes to 25 minutes. We'll be doing it after the session. So, it's basically a state where you are having a lucid sleeping, and the EEG at that time, done by researchers in our institute, had said that you have an EEG, which is an alpha EEG, and there is an increase of intermixed delta during that state, but you're not in sleep. Okay, do you know this the EEG activity in sleep? What is the EEG activity in stage 1 sleep? So first thing that happens in stage 1 sleep is when your eyes are closed, you're not sleeping. What is the activity? Very good. So resting state just before sleep is alpha. The first epoch of sleep is when the alpha drops off by more than 30 minutes. No, alpha drops out. So alpha is what range? You know the ranges? 8 to 12 hours. So it's very easy to remember the ranges. The clue is D tab. Okay, D is delta, T is theta, A is alpha, B is beta. D tab, the tab. D is 4 or less than 4. T is 4 to 8. Okay, 8 to 12 is alpha, 12 to 22 is beta. It's very easy to remember the frequencies. So the alpha drops off means the frequency becomes lower than 8. Okay, and it becomes low amplitude. Okay, more than about half of the epoch. The first epoch of sleep is that. So Yog Nidra doesn't get you to the stage 1 of sleep. It gets you into an alpha intermixed with delta. So this was the registration. It was a registered study because nowadays you can't do any clinical trial. Whenever any one of you ventures into a clinical study, you have to register it with the National's Clinical Trials Register, which is a CTRI. How many of you all are aware of CTRI? Okay, good. So this is just to show you the comparison of cognitive behavior training versus Yog Nidra intervention. Okay. So the similarities between the two are only that both are non-pharmacological. But for Yog Nidra, you require a lot of self-motivation to do it. You should be motivated. If you're not interested, if you're not going to, want to do it, you will not do it. So self-motivation is an important component of Yog Nidra. For CBTI, I told you about the cost, and there are weekly and bi-weekly sessions. You have to go to the psychologist and it's usually a multi-component therapy. Whereas for Yog Nidra, the initial 5 sessions can be supervised physically or online, and the rest is left for the practitioner to do on their own. Now there is a method of doing Yog Nidra. It is very similar to CBTI. In fact, I boldly say in most of the conference, cognitive behavior therapy was a copy of Yog Nidra, because Yog Nidra came right from before BCE. If you go into the history of Yog Nidra, it is before Christ. So the methods are, you have to prepare yourself, which we will do in the class. Then you have to take a samkalpa. Samkalpa is a thought. It can be any thought. Okay, suppose you are in a negative mode and that is causing insomnia. You can use the thought that I am a happy person. Okay, and my day will go well, and I will be able to do all my responsibilities in this happy state of mind. That can be simple sankalpa. Okay, or the more complicated one will be, I will study when I am awake and I will sleep when I am asleep. Okay, so you have to give one thought before starting it, so that you are kind of meditating on that. Then of course, just like CBTI, you have body part awareness and feeling and sensation. Sometimes some practitioners do the feeling and sensation before the body part awareness. Okay, and then visualization. You can visualize anything. When I do Yog Nidra, I visualize the things which make me happy. So what are they? Dolphins in the sea twirling around, sunflower, the sea, whatever, the green forest, whatever are the images which give you immense, or a puppy playing. Okay, so there may be some things when you close your eyes, when you think about them, you feel very relaxed and happy. Okay, now you're not to think of things which will make you tense. You have to visualize things which make you relaxed and happy. That's a part of the Yog Nidra. And then you have to end the practice slowly. So these are the 7 stages of how we do Yog Nidra, and the total duration should be around 30-35 minutes or 20-25 minutes. Is there any doubt about this? Okay. So this is where we learned. We went to the Munger school, and it's by the river, and you can see the procedure is done like this. It's basically like Shavasana. How many of you all have practiced Shavasana? Yes, Shavasana is relaxing, but this is a little more than Shavasana. It's not just the physical relaxation, but the mental relaxation which also comes into the picture. And these are the saints. Many of them are actually not Indian. In the study, we did a level 1 polysomnography. So all our patients before getting the Yog Nidra and CBTI went for level 1 polysomnography. This is our polysomnography lab, and this is where we sit and monitor. The patient is sleeping on that side. We shut the lights, we close the curtains. And we also have to have a baseline 2-week sleep diary. So any study you do must follow the modern methods. You just can't say I did Yog Nidra and the patients did very well. You have to have a 2-week sleep diary just to make sure that the patient is actually sleeping or not sleeping, or what kind of sleep is it. And we first looked at only one patient. We didn't do many patients. We just looked at one person and saw what was happening. That this is before the randomization or before the start of the study. Now, it's very crazy, but all of us who are here, who are doctors, we are very, very good at spoiling other people's sleep, especially sleep specialists. They completely ruin the sleep of their own staff. So the sleep technicians, their sleep is gone. Okay, the nurses who are in the sleep room, their sleep is gone. But that's part and parcel of evaluation of the patient. So this was our study, which was then published in the journal, and this was a randomized control study. And as you can see, this is a flow diagram of the study. So whenever you do a study, which many of you may do when you join your institutes or whatever, always have a baseline assessment period, so that you're getting a baseline as to in which you will do your sleep diary, you will do your sleep questionnaires, the insomnia severity index. You have to have a time point 0 for anything. Okay, so you do a baseline, and you see all the you can do a baseline polysomnography also, because we haven't yet started the intervention. After that, you randomize to Yoga Nidra intervention and CBTI intervention. Now, there are 2 kinds of randomization. You can have a blinding or you cannot have a blinding. In this study, it was very difficult to blind. How do you blind? You can blind the assessor, but you cannot blind the patient because they will know what is going on. Okay? And if somebody starts talking to the patient, it will be known whether he was in CBTI or he was in yoga. So this was not a truly blinded study, but it was an assessor blinded. Assessor blinded means whatever data we got from the polysomnogram, which we did comparing the baseline to the after the intervention period, was coded. So the PSGs were coded. They didn't have the name of the patient. Okay, and then somebody else is reading those PSGs who doesn't know what's happening. So you have to do that to improve the quality of your study. If you do not code and oh, this patient, she is the mother of that nurse. Okay, maybe she showed an improvement. There's a bias which comes. Okay, so always try to do that, and then we, gave them a 5-day session. Supervised sessions were 5. Okay, and then after that we allowed them to do it by themselves. So follow-up was done, and you can see here the ultimate number was analyzed: 20 in the enrollment group of intervention and 17 in the CBTI group. And you can see most of them were young. So 43, 41, Yog Nidra was 44, okay? And you can see that their parameters were comparable. Okay, the baseline parameters, when you randomize, the purpose of randomization is to remove bias and also to have matched parameters. Okay, otherwise, if you don't randomize and the person is very, very, severe, you may say, okay, let me put him in CBTI group because at least that's an established mode of therapy. So you will get a skewed, you will not get the same parameters. So randomization takes care of the parameters and they get equally balanced out. So you can see here that we did comparison of various questionnaires. So not only the PSG scores, but also the questionnaires. So there were some depression scores, anxiety scores, the Pittsburgh Sleep Quality Index, okay, insomnia severity index. All these were compared in both the groups. And of course, then you see the sleep diary. So one was the questionnaires followed by the sleep diary. And then you look at the other, compare the time in bed, the polysomnography objective thing, like how much is N1, how much is N2, how much is N3, how much is REM, and the total sleep onset latency, sleep efficiency. You've heard of the word sleep efficiency? What is sleep efficiency? Yeah, so the time spent in bed. So suppose I spent 10 hours in bed, but my first epoch of sleep by the PSG came 2 hours after I slept. So obviously, I'm not being very efficient because I'm out of 10 hours in bed, I'm probably just sleeping maybe 6 or 7 hours. Okay, so it's a time ratio. And then we compared the pre and post intervention scores and all of these. So basically, we found in our study that there was an improvement in N3 sleep. Now, what is the quality of N3 sleep? What is N3 sleep? Slow wave sleep. Is it important? Why? It is the deepest. It is the deepest stage of sleep, and it's responsible for encoding. Encoding what? What do we encode in sleep? Sleep is the best school. Okay? School meaning whatever you've learned in the morning hours, if you have to retain it, if you get into N3 sleep, you are going to retain it. So it's a best therapy for learning before exams is to sleep well. Not that you don't study. Study in the evening and sleep in the night. Your memory will be retained. So N3 did improve as well as the sleep latencies improved. Okay. So that was the effect of Yog Nidra. Then we wanted to see what is exactly Yog Nidra doing. So we looked at the various frequencies, alpha, beta, delta, gamma, and other slow activities, and we found Yog Nidra was inducing local sleep. How many of you have heard the term local sleep? Okay, so you don't, as I told you, it is not a total sleep. You're not sleeping in Yog Nidra, you don't doze off. It only induces a local frontal slowing, okay, which is there, which helps you relax. So this is what we found, and this was again very published. We did various analysis, we did mapping. So it helps us establish the electrophysiology of Yog Nidra. Electrophysiology of Yog Nidra is not sleep. It is a local form of slowing which is happening. Okay, and this was published then subsequently. Now, apart from that, apart from your non-pharmacological intervention of Yog Nidra, you also have to have a lifestyle which is conducive to giving you sleep. If you eat 5 minutes before sleeping, will you sleep? No, because your stomach is not sleeping, your intestines are not sleeping, and you are trying to sleep. So, the physiology of eating before meals should be at least 2 to 3 hours. So that it has gone down the stomach, it has gone down the intestines, and they are also in a relaxed state. Otherwise, you will sleep and you will be burping, or you will have an acid reflux. You know, some people, they sleep immediately, they lie down immediately after eating. So, what will happen? There will be acid reflux. That will prevent you from sleeping. It will cause a sleep onset insomnia. And sometimes they will just go on burping and sleep. Okay? And their stomach will be making rumbling sounds of movement in sleep. So that's not true sleep, and you are going to have to improve not only your Yog Nidra but also your Ahara, Vihara, Achara, Vichara, Vyavhara. Okay? These are old terms. Okay? Vyavhara means behavior. If you are going to be a very hyper person and not try to change that, again your sleep is going to be fantastic. So you have to learn to, and why are we doing all this? To improve our health. It's not going to improve if you say, okay, why should I change my behavior? I will be a hyper person. Okay, so that that person thinks I'm very dynamic. You can do the same activity in a very calm manner, so that your body is able to relax and sleep. So that's where Ahara is food. In the night, if you start eating all masala, oil, butter chicken, whatnot, you are not going to be able to digest. So the night meal should be very light, like a soup or a broccoli or whatever, so light food. It shouldn't be like heavy, spicy meals. So that's your ahara. Morning and lunch, you have a nice lunch, but dinner should be light. Okay? Vihara. Vihara is your where you stay. So where you stay also, if it's very noisy, there's a television playing there, big boss is fighting over there, you are not going to sleep. Okay, so that is also very important. Okay, so please keep in mind all these things. It's not just it's not just CBTI or Yog Nidra, but an overall environment which is very, very important. Now, Madam talked about about myofascial exercises, but believe me, in yoga you have very good myofascial exercises, and this is what we tell our OSA patients who don't want CPAP. We of course tell them to have CPAP because the AHI is high, but you know the problem with CPAP in India is the cost. Many people are not able to afford a 60,000 or a 80,000. 80,000 is like £1,000. Okay, they're not able to afford it. Okay, so we tell them you have to lose weight. So the first thing we have to tell them non-pharmacological is, you just don't go and say, okay, take the CPAP, you have OSA. No, you have to tell them that there has to be a change in your, especially the obese ones, at least lose 5 to 10 kgs if you can, by walking, by your diet, increase the proteins in diet, reduce the carbohydrates in diet, take low glycemic index foods. Okay, do you know what are low glycemic index foods? Yeah, so fiber. Okay, then which Indian food has the lowest glycemic index? Lowest rajma, but we kill it by having it with rice. So just take plain rajma. So besan has low glycemic index. So you have to make sure that you lose weight by low glycemic index food, no carbs or low carbs. You can replace carbs with quinoa. Okay, so quinoa is a South American Brazilian food. It's a little expensive, but it's worth it because it's very high in protein. Our diet is very deficient in protein, so quinoa can be used instead of rice. You can use millet flour, like your jowar flour or bajra flour. In winters bajra, in summer jowar. So you can replace these so that your weight is coming down, and also increase the fiber and low glycemic index food. Avoid sugar, avoid sweet syrupy things. you should definitely avoid. So your weight will come down and your obstructive sleep apnea will also reduce. And sleep on the side. No OSA patient should sleep like this. Okay, they should be sleeping to the side. So how do you ensure that in Indian settings? So you can make the bed towards the wall. Okay, whichever right wall, left wall, whichever side the person prefers, and you tell him you turn your back to the wall and touch the wall and sleep. So he gets the comfort of the wall. Or you put a big, that Gidda, you know, that big round pillow. Okay, or you put a ball in the, that's very bad. It's very, it tortures the person actually. So you put it in the vest, you put a ball, stitch a ball at the back so that he cannot lie on the back. Okay. So those are non-pharmacological measures for OSA, but in yoga we also have what is known as the Sheetkari pranayam, otherwise known as the hissing breath. Okay. So you have to inhale through the teeth. Okay. So when you inhale through the teeth, you are strengthening your muscles around the oropharynx. Okay, and it takes a little longer to do it. So that's one pranayam which involves the myofascial exercise. The other one is the twisted tongue or a folded tongue. Okay, you have to do inhalation and then exhale. This also helps your tongue and the oropharyngeal muscle. So it protrudes the tongue. So there's protrusion as well as there's suction and contraction of the oropharyngeal muscles. So these are the few exercises which we do for OSA. I think my time is, how much time did I take? Shall we go for the exercise? Yeah. Yeah, I didn't want, actually madam had kept. Okay. So I would like to tell you that normally, is it ever possible for us to have an empty mind? No. We always have thoughts, isn't it? So you will have thoughts even when you lie here to do the exercise, but watch the thoughts like you're watching a movie. Don't engage in the thoughts. Okay. So when you go to the cinema, you watch a movie, there is the villain fighting with the hero. You don't jump on the stage and start fighting with him. Okay. You are just watching. Similarly, when your thoughts come while doing the exercise, you are not to engage with them. You know, कि उसने मुझे आज सुबह से बोला, क्यों बोला, मैं भी उसको वापस बोलूँगी. No, you don't have to engage with them. That's it. Let the thought come and go. Okay? Don't entertain them by trying to negotiate them. Then, of course, the instructions will be in my voice. There will be, your eyes will be closed, so you can relax and don't worry about the surroundings, because the whole purpose is that you get to relax. Also, do not worry if you fall asleep, but try not to fall asleep. Okay, that's why we're doing it before lunch. So I think we need you to be distributed in such a manner that you can move a little to the front. Okay. Okay. Where will your head go? Just one more. You need space. That's why I said one of you can come here. Just when you lie down. So all of you can now lie down. Yes, all of you can now lie down. You can come here. 2 or 3 can come here. Remember that the most powerful energy that we have now is the planet Earth, which is exerting gravity. Okay? So the most powerful energy which we have now is the planet Earth, which has a very powerful energy, which is gravity. So please, the head also has to be, you have to be a bit down, yeah, otherwise you will strain your head. So please allow your body to rest its weight on that powerful energy source, which is gravity. Let gravity overtake your body and let your body be rested fully on the ground. The weight of your body should be on the ground. Now slowly take your hands away from your body to 30 degrees laterally, 30 degrees only, not 90 degrees. So just the palms should be facing up and open. The palms should be facing up. Last person, yes. So palms should be facing up and open and relaxed. Now we will close our eyes. Very good. So just try to get comfortable in this position so that you are not going to be distracted. It's okay to feel itchy. It's okay to, if you can't bear it, lift your hand and scratch your nose. Because, just when we try doing yoga, the most difficult thing is to lie without any movements. Okay? So try to do, if it becomes unbearable, you can, of course, scratch your nose or your head or wherever. So remember, now we will get you to relax a bit more. Okay. Slowly inhale and exhale through the mouth. Ha! Slowly inhale and exhale through the mouth. Slowly inhale and exhale through the mouth. Slowly inhale and exhale. Now, each one of you will try to gather one sankalpa or one very light idea or one very light motivation, whatever. It may be that, I am going to relax and go back and study, or I'm going to relax and be happy and have fun today with my friends. So any one idea which for basic humanity in yoga is an idea which neither hurts oneself. It's very important that the idea you have does not hurt yourself or hurt any other organism. human or non-human. So whatever idea you are taking in should be an idea for mutual happiness, not hurting yourself nor the other. If we have gathered such an idea, we will move to the next phase of Yoga Nidra, which is body part awareness. First, we do the right side of the body and then the left side of the body. Slowly bring your awareness and your breath to focus on the right thumb. Just focus and relax your right thumb. You have to relax it. So to relax it, sometimes you may stretch it and then relax it also. The breathing has to be slow. Now you relax your pointing finger on the right, the middle finger of the right, the ring finger of the right, the pinky finger of the right. Now you relax your right hand, the front and back of it. We then relax, breathing very slowly, the forearm, the front and back of the forearm on the right. We then relax our right elbow, the front and the back. The right arm and upper arm. Try not to move the part, just feel it relax. We now relax the right armpit, the right shoulder, front and back, the right chest, front and back. Breathing slowly. The right trunk, front and back. The right hip, front and back. The right thigh, front and back. The right knee, front and back. The right leg, calf, front and back. The right ankle, just visualize your ankle, front and back. The right foot, upper and lower. The toes of the right foot, all the toes, the great toe and the little toes. We now bring our awareness to the left hand. We relax the left thumb, the left pointing finger, the left middle finger, the left ring finger, the left pinky. Then relax the left palm and the back, the left wrist, the left forearm, the left elbow, the left arm, the left shoulder, the left armpit, the left chest, front and back, the left trunk, front and back, the left hip, front and back, the left thigh, front and back, the left leg calf, front and back, the left foot, upper and lower, the great toe, and all the sweet small toes. We now move our awareness to our neck, the neck which supports the head and the brain. We relax the neck completely, always holding the weight of your head. Let it relax. The chin, the right side of your face, the right side of your forehead, the left side of your forehead, the left side of your face, your nose, your left ear, your right ear, the back of your head which is touching the ground, the back of your head which is touching the ground. And we then move to the highest point of our body, which is the vertex or the point of your head on the top. Be aware fully that certain points of your body are touching the earth. The back of your head, both your shoulder blades, your buttocks, and your ankles are touching the ground. Let the weight be on the ground. Now, all you have to do is breathe in very slowly, hold for a few seconds, and breathe out through your nostrils very slowly. Remember, the breathe in, if it is of 4 counts, the holding of breath should be of 6 counts, and the exhalation should be of 8 counts, so that all the impure air is exhaled out. So breathe in, hold, exhale. Breathe in, hold, exhale. Breathe in. Hold. Exhale. Breathe in. Hold. Exhale. Do this for a few times on your own. Now that you're aware of your breath, the breath is what keeps us going. You are now aware of your breath. Slowly shift your awareness to the sounds around you. Do not open your eyes. Shift your awareness to the sounds around you. So, along with your breath, you are now aware of the minutest sound around you. Now bring your awareness back to your breath. Only inhale, hold, exhale, inhale, hold, exhale. Now bring your awareness to any sensation which you feel. It may be the fan fluttering your clothes. It may be just the touching of the body on the floor. Any sensation that you feel. Bring your awareness to that sensation. Now bring back your awareness to just your breath. Slowly breathing to comfort yourself. The breath must comfort you. Now we move to the next stage where you will bring your awareness to an area between your eyebrows without opening your eyes. Bring your awareness to either the front of your eyes, just above, that is your eyebrows, or inside your head, behind your eyebrows. Bring your thoughts and visualize. We as humans have a gift of visualization. We can visualize anything. Visualize those things which make you happy. The laughter of a child, your mother's smile, going to the mosque and praying, going to the church and hearing the church bells ring, going to the temple with fragrant flowers, any form of thought which gives you happiness, seeing a big bright sunflower, stars, chirping birds, singing happily, a peacock shouting because of rain, a peacock dancing in the rain with its feathers spread out, dolphins chattering and skipping through the water, green forests with the breeze in them. Experience the breeze of the trees and the green forests and the pure air. The sea and its waves, the sound of the sea. These are just examples. There could be many more things that give you individual happiness. Just think of those things and visualize them in front of your eyes. These things which give you happiness will also relax you. Keep your eyes closed. While visualizing, breathe slowly. If you have visualized all the things that give you happiness, now bring back your awareness to your breath. Breathe in slowly and breathe out slowly in a relaxed manner. Move your awareness now to both your feet again. Both your feet. Then move your awareness to the front of your legs. To the front of your legs. Move your awareness to both your knees. Move your awareness to your thighs. Move your awareness to your pelvis and hip, the front. Move your awareness to your abdomen, front. Move your awareness to your chest. Move your awareness to both your palms, the front. Move your awareness to both your forearms, front. Move your awareness to both your hands, the arms front. Now move your awareness to your neck, to the face, to the top of your head. Release the pressure from the top of your head, the back of your head, the neck, back, the shoulders, back, the spine and the trunk, back, both your arms at the back, both the forearms at the back, both the palms at the back, both your buttocks at the back, both your thighs at the back, both your calves, both your feet. Your body is now relaxed. Remember that whenever exhausted, the simple exercise can help you regenerate. Focus back onto your breath. Loosen your body further. Now, bring both your hands together in front of your chest. Nicely warm. Press them against your eyes. Press the palm against your eyes. Palm against your eyes. Lightly. Bring your hand. A life experience. All of us are basically experiencing things from minute to minute, second to second. Whatever experiences are precious and happy, keep them with you for this process, because that also helps you regenerate and relax. And then again you have to breath awareness, body part awareness, then your hands together. You can't just get up like that. Okay? Your hands together, rub them so that a little bit of muscle strength is there, and then your eyes, and then get up. Okay. So this is Yog Nidra. It's very simple. The same thing is done in CBT. But CBT has two components. It has a cognitive component. Okay, it has a behavioral component. So depending on the reason it is being done. So CBT is done for post-traumatic stress disorder. Many people have post-traumatic stress disorder, particularly in the times of uncertainty. Or in COVID times, people died. Many of our family members died. We were not prepared. So it leads PTSD happens. If somebody has gone out to the war and comes back from the war also, they have a lot of PTSD. Suddenly there is an untimely death of not a proper age. 30 years person died in the family. Then the mother, the sisters, brothers also can have stress. So CBTI can be done for them also, but that is requiring you to have a psychologist. Now, once you start doing this slowly on your own, you can do it on your own at home, the Yoga Nidra. So there are YouTube videos which are there. So if you write YouTube video for Yoga Nidra practice, the next 5 sessions you can do that. And after 5 you become an independent. So it's virtually very, very addicting because it gets you to relax. And actually with Yoga Nidra, you don't feel sleepy also so much in the morning hours, but in the night you will sleep. How many of you keep a diary?
It's a journey.
Yeah, journal. So the other way to relax is to write a journal, and before you sleep, you write your worries in the journal. So suppose you were not able to read chapter X today. Write down, I was unable to read it today, but I'm sure I will do it tomorrow. Don't keep thinking in your sleep that I didn't read, I didn't read, I didn't read, you will not get sleep. So it's called a worry diary, and you have to maintain it so that you can prepare for the next day and then sleep. Any questions? Any questions?
Isn't it better when someone else is giving directions like this? Can the results be, let's say,
So that is why in the YouTube video, when you do it, you can do it with the voice play. There are YouTube videos where the voice plays and you're just doing it.
you can like the research that you're doing?
No. So the first 5 sessions in our research were supervised like this, and then they did it on their own. So then you have to maintain it on your own. It becomes a habit. Some people are not able to do it. Some people are not able to do it. You can use the YouTube instructions.
Why does it happen that our mind is distracted even we are doing yoga during the
So that is the nature of the mind. You can't struggle with it. Don't even try to struggle with it. Like you think, I will control my thoughts. I will control my thoughts. More than thoughts. Okay? So you just leave it. It's like if, if somebody is doing some mischief, like a small child, you can ignore it. So that then generally children will do some mischief to get what? To get attention. So that thought of yours is also begging for attention. So if you interact with the thought and you start making stories out of the thought, okay? So she's sitting next to you, you think, why did she look at me that way? Maybe she doesn't like me. I will also not like her. Tomorrow I will not give her my lunch. So it becomes a story. Okay? So that is what the mind does. The mind is craving for existence. We exist because of our mind. So it's craving for existence. So in one way, if you are ignoring irrelevant processes, you will be able to focus on the more relevant ones, which is your studies or your helping your mom out, rather than engaging in all irrelevant messages that your mind is giving. It will, because mind is an absorbent. There are so many thoughts in this very room. We live in X, Y, and Z axis. There are many domains which we are not aware of. And the thought domain is a very powerful domain. The thought domain, you will see your thoughts change according to where you are. If you are in an institution, your thoughts will be about your studies. If you go to a disco, your thoughts will be about the disco. If you go to a mosque, your thoughts will be about prayer to the higher energy. So your thoughts vary according to your environment because many people in that area are having the same, probably the same thoughts. This is one hypothesis. Don't ever try controlling your thoughts. I also don't do it, but just let them go. That's one way to reduce them. If you start engaging in them, they make stories. The thoughts will generate stories. So a thing won't have happened, but you will create a full story out of it and you'll have an anxiety attack also.
why I keep changing the focus it's giving me
Because otherwise you will go to sleep.
it's giving me anxiety.
Changing the focus from here. So that if I just leave you like that, then most likely you're going to go to sleep. Because it's a very nice room, it's quiet, so you don't want to be in sleep, you want to be relaxed. But at the same time, you don't want to be anxious. You can do it naturally. So first you have to accept that you're doing it for anything to not produce anxiety, you have to have an acceptance, isn't it? Suppose you're doing a course here. If you're not accepting the course, suppose she's going to learn sleep medicine. She doesn't want to do sleep medicine, she's been forced to do it. She'll have more anxiety about it. But if she's mentally prepared, now I have to learn about sleep, the stages of sleep, the polysomnography, she'll be able to accept it better.
Now can this focusing on thoughts which we are doing while we are moving at all in the long run can we just while we are performing something like while we are doing certain activities can we just focus on one thought and perform like controlling our thoughts when we are doing a particular.
That's what happens when you study. When you study,
But there are
if you clearly if you look at your studies, okay? This is not my saying, it is my daughter. She is a psychiatrist. So she used to tell me when she studied in Hamdard, she did her MBBS in Hamdard. So she used to tell me that when she studies, she feels that she is meditating because the thought is only in that. So that was a form of meditation. For every meditation, you don't have to close your eyes and chant or do. You know, even the fact that you focus on your studies and your thoughts is on that process is a form of meditation. Have I answered you or not answered?
someone starts crying while doing this. So is it normal or is it something like underlying anxiety or something?
So everybody has a different emotional state. Not all of us are in the same emotional state. And the emotional state may not be the same at every point of time, even for me. So generally, I'm a very positive person, but then sometimes you get into a negative. So you need not have, you don't have to feel embarrassed about it because all of us go through these emotional states. You just have to accept it. But you have to be aware of it. Suppose you're getting anger, you have to be aware you're getting angry. Just awareness is good enough.
But if someone is performing this yoga and then they are feeling anxious or like they are not feeling anxious, but if they are feeling like crying, so they want to.
You can cry. You can cry. People laugh also. People go into very deep laughter during this exercise.
Then तो फिर वो concentrate नहीं कर पाएंगे कि वो तो चाहेंगे तो
But you can't even suppress your emotions. No? That's not good. Suppose you're in your room and you're just wanting to cry. That also relaxes you. I don't know if you've observed it. Sometimes just crying relaxes you. Sometimes just laughing relaxes you. So as long as you're in your own friend company, not in company of people who will make fun of you or who mind that.
How come if someone has problems supplying lines, so can it be performed in any other?
Ideally, it should not be done in prone. You can, if you're not able to lie, you can put a small, towel beneath your legs. Because some people have back pain, so for them we tell them roll a towel and just put it below your knees, so that the knees are slightly bent. So that will help the backache people. So backache people will have a problem.
मैं पेशेंट को tinnitus
हाँ?
tinnitus का पेशेंट
Tinnitus.
मुझे डॉक्टर ने कहा कि आपको अडेप्ट करना है।
हाँ.
मैंने कहा कि फैन तेज चला देता हूँ फिर मैं सोता हूँ क्या जैसे लाइट 50 मिनट
So with the fan, the tinnitus gets suppressed, is it?
हाँ मैम जैसे उसकी आवाज़ आती रहती है तो मैं सोता हूँ।
Okay, so you're masking your tinnitus with the fan sound. So that is what there are masking devices present for tinnitus. So those devices are worn in the ear, they mask the tinnitus sound and they generate another sound. So you are doing it with the fan, which is the sasta way of doing it.
लाइट गोज तो नींद खुलता है।
हाँ तो होगा, वो तो वैसे भी खुल जाती है सब। अभी गर्मी है, फैन चला गया तो उठो गया नहीं उठो गया।
अगर ठंडा भी रहे कुछ है फैन बस वही
You are doing your best, I can say. I don't know if there's anything specific for tinnitus because that's not my area of specialization. I can find out. I have a student of mine who's now joined the yoga college, so I can find out from him. I'm not aware of it.
Ma'am, if the thoughts are too negative, that you wait in another positive thoughts during the whole process, then how to focus and how to overcome this?
So yes, there can be conditions because of our life experiences that we have probably not had any positive thought or positive experience. In which case, you will have to do a hypothetical scenario and get into the habit of doing it. So, you would have in your mind at least thought what gives you happiness. That's a different thing that general thoughts are negative. But in your mind, you would have thought, like, if I get this, I'll be happy. Or if I see this, I'll be happy. So you will have to generate those thoughts.
And how similar is insomnia patients will
So we gave them 5 practice sessions which were supervised, and then weekly sessions which were done for the next 3 months. After which they showed an improvement. So it's just about a week to 2 weeks. Some of them report a very early improvement, some of them take a month.
But empirically, how is the safety feature when done at night? If it's sleep, it was done in the morning.
No, this is not done in night. Yog Nidra, excuse me, I want to tell you, Yog Nidra is never done in the night. It is done empty stomach in the morning. So that it's working at various levels. It's working at thought level, it's working at relaxation level. Don't do it just before you sleep. Just before you sleep, you cannot just go on thinking about every part of your body. Before you sleep, you can do Shavasana. Just relaxation. That's it.
Ma'am, but the instruction you were giving during the session is same for all, like if anyone is having PTSD or anxiety or other disorder, the
Yeah,
instruction is always the
so
same.
that's a very good question. So this is a very non-specific. It's not Yoga Nidra is not targeted for anxiety or PTSD. You will have to talk to a psychiatrist to deal with that. It's not taking away the role of the doctor or the psychologist. If there is PTSD, if there is stress, you should seek professional help. The reason being, these professionals are trained to pull you out from that situation slowly. But if you remain there, then there can be negative effects to your life. So always seek professional help.
While practicing the visualization which was, so it was a thing like I was able to think of things which made me happy, but then I was not able to clearly visualize them, and after some point, it was completely blank.
Yeah, so that's perfectly okay. I mean, this is just a trial session. It's perfectly okay. There's nothing wrong in that. There's nothing wrong in anything. Okay. So maybe next time you'll be able to see the sunflower, or maybe next time whatever you see a bird or whatever. So it's you can visualize. You can also think. Um, so if you look at your thought process, we do have conscious thought process which we are aware of, but a huge amount of our beliefs and perceptions are in the subconscious realm, and the subconscious realm actually drives the conscious realm. So when you relax, you will be able to sometimes even touch the subconscious realm. So don't feel embarrassed if you're not able to see it.
From now. Actually, we had one Malaysian delegate at SVT, few months back only, and he introduced us with the imagery technique, imagery exercise technique. So it was somewhat similar. Please enlighten me how it is different. The
So in
yoga.
CBTI also, you have visual imaging. You have body part relaxation, visual imaging. The processes are the same. Okay. Now visual imagery is again the same, that you visualize things, and certain psychotherapists and psychiatrists, they will do regression, particularly in post-traumatic stress disorder, as well as you heard of past life regression. So many people who believe in past life, they do the psychotherapist does a past life regression, where they kind of go into a state where they are made to probably recollect whether they are true or imaginary. We don't know. It's a therapy. So when they imagine, okay, so for example, I'll give an example. There is this person who has whose brother was killed by someone. Okay? And he goes to the psychotherapist. It's a true story, true incident, which because I did my post graduation from NIMHANS, and psychiatry is a big part of NIMHANS. So we used to have a 6-month psychiatry course. So the lady who does the past life regression, she was taking a class for us, and the patient, the video, we get to see the videos as a part of the training, and she took him into a past life regression. Now he recollected certain events which made it seem that there was something wrong which the brother had done and their family had done in the past life. And so, out of repentance, now, on whom it was done, that person does it on. Now, one doesn't know whether those events happened, but it is used as a form of therapy so that the person is able to forgive and get out of that state of, the bitterness, trauma of somebody killing you. So, past life regression therapy is that. Similarly, visual imagery is also something which you visualize. Now, you could say you are tricking my mind, or I mean, there are so many things we do. Okay. We drink, we may smoke, we may hang out with friends, we may spend our parents' money. This is the simplest, least expensive, easiest, non-harmful thing to do. To visualize something which makes you happy. What else? I mean, no, you're not paying anybody money for it. You're just feeling happy out of it. Okay?
So, utilizing it for the sports athletes to train them
Yes.
for the
Yes.
virtually without exerting, without.
So visualization is a very good tool to move towards your goal. Okay? Visualization therapy is done to move towards your goal. So they say if you visualize, suppose she wants to visualize she's a doctor. So she wants to be a doctor. So one visualization therapy is that you just sit down, close your eyes and visualize the different stages and the different how you will wear a dress, how you will, and be a doctor. Okay? So not that you become a doctor just doing that, you have to study. Okay. But that's why you go all sit visualizing and then you say, I will visualize and you become a doctor. Not like that. So it's one of the things which is used towards improving your approach towards a goal. All sports medicine, the mind has a lot of role even in sports. The state of your mind can turn the team into being a winner or a loser. That has got nothing to do with yoga. This was just yoga. I think we are done, yeah.
Whenever I practice this yoga, whether in the whole life is quite related, I'm able to get the good thoughts. But after the end of session, like after 2 or 3 minutes, it's like my heart is quite heavy and I feel like all the sad experiences of my life. And sometimes I feel cry a lot. And my blood pressure will rise and rise and rise and my body starts to shiver.
Have you been practicing regularly?
So no, due to this thing, I'm not.
That is strange.
Like now my heart is like, and my body is like shivering. I don't know why.
So that means after that you will have to sit down and just do relax breathing for some time. Don't get into your worldly activities immediately. It can happen, and that is why they say that the first ICU session should be supervised.
Is it did it the sleep time and stuff or only the daytime?
Everything improved. The stage 3 sleep improved. The total sleep time improved. The sleep latency reduced. Yeah, we are done. Thank you. Thank you all. So try to do it with the YouTube and then.
Which includes your NCD, EMG, we have the TMT, we also have the training gym. Along with that, we also have the what else? The HRV, the HRV thing. Okay. So all of these, the students who are over here who are doing their PhD as well as the master's work are using these equipments to substantiate their work, whichever we are doing. In the center, we are very particular about the subjective and the objective measures. Each student has to have a subjective measure and along with that an objective measure is mandatory. Without the objective measures we don't do even the master's work. That is why maybe the rate of publication from us I think is much higher. And the equipments which are used here are used interchangeably. It is not fixed that this equipment is for orthopedics alone or this is for neurology alone. The equipments are mixed up. And similarly the students who are doing the sleep work are also using these equipments because we are trying to find out the correlations in between these and sleep. Along with that, as far as sleep research is concerned, after 4 days you must have realized that the amount of research available in sleep is much lesser. There is a lack of the normative data. So a lot of work which is being done in the center right now is also about developing some normative data as far as the correlations with sleep is concerned. So for example, autonomic nervous system is one thing which we are keenly working on right now. We have worked with autonomic nervous system in patients who are normals. We have worked on subjects which are normal, then we also have worked on subjects who have back pain along with that or neck pain. So a few of the students have also worked on trying to find out the correlation in between physical activity status and sleep and HRV. We have also worked on working women and how is their sleep associated with their HRV, where the physical activity status is poor. Some of them are intervention studies, some of them are observational studies. So both kind of work has been done. As far as the HRV is concerned, we have done both experimental studies where it's a one-time study. One-time studies are usually going to be giving you the data regarding your developing of the normative data, and two-time studies, usually post and pre-studies when we do, they are more indicated towards finding out the effectivity or efficacy of the interventions that we are doing. The interventions, as far as they are concerned, what we're doing in the center is concurrent exercises. We're talking about resistance training, we're talking about MFR, we have worked on what else? The body vibration we have worked on, and of course posture correction, because there is a study with the posture studies, so a lot of posture correction studies, sensory motor training. So all these things we have either worked on or are in the process of working as far as the intervention is concerned. So these are some of the students who will be showing you the various equipment. So you can come in the front and have a look at the equipments here. From there we start. So this is the first one, that is an NCB equipment here. Maria would explain it to you because she's working on it. Maria, you are explaining or she's explaining? Maria, everybody can see it? Move the curtain on the side. नहीं, ये बीच में ही रहेगा. बीच में रहेगा. नहीं, वो नहीं जाएगा. Okay, everybody can see it? Yes. Okay.
So here's the equipment we are having here. That is the RMS Saris 2C. This is the Indian manufacturer modality that we are having here for our study. So by opening the software, can everybody see?
You can come in the front. You can come in the front. Yeah, it's okay. You can come in the front.
So in our NCS study, basically nerve conduction studies, we are mainly see the velocities, sensory nerve conduction velocities, and we compare it with their different latencies, amplitude, and many more factors which are related to it. So once we are dealing with that, we have to see what nerve we want to test, whether it's sensory, motor, and mix, right? So when we are talking about upper extremity, where we have a number of nerves like including motor nerves, motor, radial and ulnar, and median, motor, radial and ulnar, and in lower extremity where we are having like sensory, many involving like superficial perineal nerve, sural nerve, and in motor like we can take any of those like tibial and many more. So in this parameter that we have seen, like there are given some predefined parameters. If we can use it, we can't change it. It's predefined. Like it's suitably for all the patients. We are not going to change anything, regardless where we want to see the things which we can control accordingly by giving all the information on the screen. So here I have taken some patient's data, as you can see here. Data which I have taken from the patient. She is a diabetic patient, and I have taken it the motor value of median nerve, motor NCV value. So the threshold and the latency have been, I have seen it like it's decreased. So I can compare it with the normal distribution of the same from a normal person, right? So this is the study which I'm seeing. I'm seeing the differences in all the velocities, latencies, and I can compare it with the normal population group, whether it's related to the amplitude, latency, and many more. So these are the things which I have seen it, and I'm just comparing it. And by talking about the electrodes, we have 3 electrodes we are using it: active, ground, and reference. We can keep it accordingly to the area which we want to test it, depending upon the sensory and motor.
Any questions regarding NCB? So this is the Delsi EMG machine that we have. Again, most of the students who are working on EMG are I think majority of the students from all 4 specialities are working on the EMG machine also. In EMG, one of the studies which we did in a center on neck pain patients, we showed an improvement in the EMG, and the EMG correlated with the sleep parameters in patients with chronic neck pain. The EMG parameters improved after giving an MFR. We also did a study in which the entire night recording we did for trapezius in patients with chronic neck pain, and we compared these recordings and these activities with the PSG parameters of the night. And we found a correlation in between them. In patients with chronic neck pain, it was found that the trapezius was much more active as compared to patients who were normals, and then after post-intervention, the readings of the EMG, the firing of the EMG went down during the night also. Okay? Ritika is going to explain you about this. Ashok, come this way. So this is the Dentist machine. These are the electrodes. We use wireless electrodes for this machine. These are the electrodes. There are 6 electrodes which we have over here. And to pair the electrodes, first we have to charge them. Okay. After charging the electrodes, we open the Trigno software. The software used for this Dentist machine is the Trigno software. When there is red light, it means that the electrode is charging. This electrode is not charged, so it won't be able to connect it. This is a pre-recorded EMG reading. You can have a look at this. So we can check the RMS value, RMS, MVIC, onset latencies, mean, standard deviation, ये सब हम चेक कर सकते हैं जो भी हमने रिकॉर्डिंग की है उससे. जैसे हमने इलेक्ट्रोड प्लेस कर दिया तो पेशेंट को ना थोड़ा विसिनिटी में नजर आ जाना होता है क्योंकि वायरलेस सिस्टम है. ज़्यादा दूर जाएंगे तो फिर कनेक्शन फिर उसमें से खराब हो सकता है. तो बेसिकली जैसे अगर हमने फिर जो हमने रीडिंग ली उसको सेलेक्ट करके हाँ तो हमने ये सारे वैल्यूज देख सकते हैं. मतलब नॉट जस्ट द RMS वैल्यू बट यू कैन ऑल्सो सी मीन, मीडियन, स्टैंडर्ड डिविएशन, स्टैंडर्ड एरर, RMS और सारे वैल्यूज हम इसमें देख सकते हैं. तो लेटेंसी भी अगर हमें निकालना है कि कौन सी मसल पहले एक्टिवेट हुई है वो सब भी हम इससे कैलकुलेट कर सकते हैं.
एक चीज़ और है कि इसमें मल्टीपल इलेक्ट्रोड एक साथ लगा सकते हैं. जैसे अभी तो एक रीडिंग आ रही है कि यहाँ पे EMG फ्री वाला कनेक्ट है.
हम एक बार में 6 मसल्स की इसमें रिकॉर्डिंग ले सकते हैं क्योंकि हमारे पास 6 मसल्स
तो यहाँ पे 6 वो आ जाएंगे हमारे आउटपुट और हम 6 रिकॉर्डिंग एक साथ ले सकते हैं. ये वाईफाई के थ्रू तो नहीं करता है इसमें. प्लेसमेंट के लिए आपको क्या करना होता है इस पर
प्लेसमेंट की ना हमारे पास सीनियम गाइडलाइंस भी होती है. आप इंटरनेट से मिल जाएगा.
EMG का सीनियम गाइडलाइंस होती है कि आपको कितने उस पर प्रपोर्शन पे कितनी मसल की लेंथ पे हमें किस अकॉर्डिंग में लगाना है. हर एक मसल की अपनी अपनी एक पोजिशनिंग होती है.
जैसे ट्रेपेजियस का होता है कि आपको एक्रोमियन और नेक के बीच में हाफ डिस्टेंस में आपको यहाँ पे लगाना होता है ट्रेपेजियस के लिए. फिर आप ट्रेपेजियस की एक्टिविटी कराओगे शोल्डर शर्ट तो उससे फिर हम RMS वैल्यू ले सकते हैं. फॉर MPIC उसी में आपको रेजिस्टेंस प्रोवाइड करना, पेशेंट को बोलना है टू स्ट्रक द शोल्डर. तो उसी में हमारी MBIC की
इसमें हम कोई भी प्रीवियस आर्टिकल वगैरह से रेफरेंस ले सकते हैं कि हमें कितने टाइम तक कॉन्ट्रैक्शन कराना है। लाइक MBIC के लिए आपको कोई 5 सेकंड्स का भी लेता है या फिर 3 सेकंड का लेता है, उस हिसाब से आपने अगर 5 सेकंड का लिया है तो उसमें से 3 हम एवरेज 3 रीडिंग्स लेके उसका एवरेज निकाल लेते हैं, जो कि हमें फाइनल उसमें हमारे काम हो जाएगी।
Any doubts?
आपको सबसे पहले याद रखना है इलेक्ट्रोड लेना है, जिसे हमें क्वाड्रिसेप का चेक करना है, ठीक है। तो RMS के लिए हमें क्या कराना है, बेसिक क्वाड्रिसेप मसल का फंक्शन कराना है, तो क्या है नी एक्सटेंशन। तो पेशेंट अगर सिटिंग पोजीशन में है तो उसको हमने बोला पेशेंट सिटिंग पोजीशन में है, नी एक्सटेंड करने बोले उसको, ठीक है। तो RMS वैल्यू दे देगा, यहाँ पे ग्राफ बनना शुरू हो जाएगा, ठीक है। यहाँ पे टाइमिंग इंटरफेस आ रहा है कि हमें कितने कितने उसका लेना है, कितना हमें
सेकंड्स में ये वैल्यू आ रही है 1 2 3 4,
कितना हमें ग्राफ सेलेक्ट करना है, उस हिसाब से यहाँ RMS वैल्यू शो कर देगा। फिर नेक्स्ट क्या करना है, हमें MBIC कैलकुलेट करने के लिए पेशेंट को आइसोमेट्रिक कॉन्ट्रैक्शन करने बोलना है अगेंस्ट मैनुअल रेजिस्टेंस, ठीक है। फिर उसके बाद वो करेगा, उसकी भी हमें 3 बार कॉन्ट्रैक्शन करा के देख लेना, और जो हाईएस्ट वैल्यू आएगी हमें वो कंसिडर करनी होती है कि जो हाईएस्ट वैल्यू।
जैसे हमने ये टाइम सेलेक्ट कर लिया 3 सेकंड से 6 सेकंड्स के बीच में, उसके बाद फिर हम गए इसमें, फिर हमने देखा RMS यहाँ पे लिखा हुआ है RMS, फिर हम RMS पे क्लिक करेंगे तो हमारी RMS में वैल्यू आ गई 0.12 आएगा। तो अपने पेशेंट को
और जैसे ही हम इसमें ना यहाँ पे एक वो करके मार्कर
को जब स्टार्ट करेंगे ना, जैसे अभी तो स्टार्टिंग में ये कनेक्टेड नहीं है, स्टार्ट करेंगे तो उसको हम कमेंट ऐड कर सकते हैं कि अभी हमने पेशेंट को कमांड दिया, तो उसके बाद फिर हम टाइम उसके अकॉर्डिंग ले सकते हैं। 6 सेकंड्स का टाइम दे दिया,
उसके बाद हमने अभी तो RMS लिया, फिर उसके बाद हमने MBIC लिया। फिर MBIC के लिए भी सेम हम RMS वैल्यू लेते हैं, बट वो मैक्सिमम कॉन्ट्रैक्शन के साथ लेंगे, आइसोमेट्रिक कॉन्ट्रैक्शन के साथ।
मतलब MBIC में आपको अलग से दिखा देने कि MBIC है, मतलब उसमें तो हम रेजिस्टेंस दे रहे हैं ना, तो वो मैक्सिमम कॉन्ट्रैक्ट कर रहा है, वैल्यू तो RMS ही लेंगे, वैल्यू है वही वैल्यू ले रहे हैं।
तो RMS और MBIC वैल्यू आ जाएगा, उस हिसाब से हम फिर मीन एस्टिमेट निकाल के हम देख सकते हैं, कंपेयर कर सकते हैं कि क्या हमारे रेंज आ रहा है कोर्स का।
Okay, please we move this side now. So this is the equipment which is So this is the equipment which is which is basically being used for measuring the autonomic nervous system. The device is there. She's going to be explaining you about the device, and we already have a preloaded available there for the one case that was recorded. So she's also showing you how the recording looks like.
The HRV heart rate variable shows about the cardiac autonomic function system, how the sympathetic and parasympathetic are working. The software here is a lab chart 7. Okay, this is the lab chart 7 software, and the power lag system is connected to it. So there is a 3 electrode that follows the lead to pattern of the ECG placement. The white electrode should be placed on the right malleolus here, and the black one should be placed on the left side on the left malleolus, and the green one should follow the right leg on the right leg malleolus. Okay. So follow the lead to placement. They are the very prerequisite for proceeding the HRV, and the patient should not be consumed the caffeine 24 hours before the HRV demonstration, and exercise should not be done 2 hours before, and the patient should not have taken the heavy meal 3 hours before, and there are various prerequisites before proceeding the HRV, because it has having a various confounding variables that will affect the study. And the place should be very calm, मतलब शांत रहना चाहिए बिल्कुल, क्योंकि HRV की वजह उससे बहुत ज़्यादा हमें वेरिएबिलिटी देखने को मिलती है अगर ज़्यादा नॉइज़ होगा। तो सबसे पहले हमने HRV का आफ्टर लैब चार्ट ओपन करने के बाद देयर इज अ सब्जेक्ट डाटा, वी शुड पुट हियर द नेम, एज एंड द मेल. It should vary from the gender to gender, age to age. The HRV data is valid. Okay. So on the channel 3, we put the digital filter of 40 Hz cutoff frequency. After that, we we put the electrode, we instruct the patient to be calm and अपने आँख को बंद करके आराम से सो जाए. ज़्यादा कुछ सोचने के लिए मना करा जाता है क्योंकि इससे हमारे HRV पे इफेक्ट पड़ता है. And the basic definition of the HRV is the differences in the interbeat interval, the differences in the time interval of the various RR interval. Okay, and our heart is not a metronome that it should be repeated only after a limited second, only after 30 seconds it will beat. So the variability should be there, but variability should not be very much. Otherwise, it shows there is some pathological condition. Okay, so HRV is basically showing our sympathetic and parasympathetic system. There are two domains. There the time domain that shows our in the time indices. And there is a frequency domain that is it is divided into various bands, low frequency, high frequency, ultra low frequency is there. So I will show you the report here. The time domain indices included the SDNN, standard deviation of NN interval, and then there is a RR interval. After removing the ectopic beats, we are having a normal to normal interval. So this is SDNN. In the time domain indices, we are having SDNN, RMSSD, PNN 50, and various total power should come in there. And in the frequency domain, we are having a LF, HF, and LF by HF ratio. So the sympathetic SDNN total power and the LF by HF ratio shows our overall HRV. That is showing the sympathetic and parasympathetic both. And the RMSSD value, PNN 50 and the HF showing our the parasympathetic system. The value here is showing, and the LF showing, and the SDNN there is a conflict in between it is showing overall or this is showing the asympathetic. Okay, so the LF and the SDNN shows our sympathetic system. The SDNN value should be greater than 100. Okay, for healthy population, 50 to 100 is for the compromised health and less than 50 is for the unhealthy population. This is the data of a patient suffering from the hypertension. That's why the SDNN value is the 42, which is comes under the unhealthy population. Then there is the RMSSD value. It should be also the higher than the 50 millisecond. Then the total power it should be greater than 1000 for a healthy population. Then there is the LF and the HF value. LF showing our the sympathetic and the HF showing our parasympathetic system, and the ratio is showing our the dominance here. If the sympathetic is more, then our ratio will be greater than 1. Then there is a sympathetic dominance is there. So it basically understand our very well how our sympathetic and parasympathetic is worked. For our resting condition, parasympathetic should be dominant so that all the vital organs should work properly. And for any fight and flight condition, the sympathetic should be predominant. So this is the sympathetic.
You saw the PhD lab just now. Now this is the clinic where we are seeing all our OPD patients, and as well as that, the students who are doing the research are also collecting the patients from here if they are working on the patients. If they are working on normals, then of course across the university they have access to the neighboring area depending on the inclusion exclusion. But as far as the patient supply is concerned, this is the major area from where we are getting the patient supply. Along with that, the amount of OPD that we have varies between 65 to 75 to 80 also at times. The clinic is open to outsiders as well as to the Jamia faculty and the students. It is open for them also. And the clinic timing usually we start at 9:30 and we are going on till 5:30 with a break of around half an hour to 45 minutes in the middle. We have 2 clinical therapists who are designated for the clinic completely. Along with that, the students are posted here, of course, and the faculty is also coming here on rotation. We have some equipments here which are imported, and we have some Indian equipments also. And usually we are giving the clinic is working on an appointment basis, and the variety of patient ranges right from ortho to neuro to pediatrics. We have almost all the kinds of cases reported here. She is Dr. Bushra. She is in charge of the clinic here. She will give you a demonstration of the clinic.
So this is the electrotherapy unit of ours. This is from Zimmer. Basically we said it's Zimmer, right? And this is from German. And this is from Intravenous laser machine, right? And we have all the currents that you must all be knowing about this. And we have Intravenous laser here, right? And Intravenous laser is one of, we have one more there. But we have 2 ranges here, 5000 to 250 hertz, watts basically, right? Any question you want to ask about it, you can ask. I can show you some other. Just the electrotherapy, not just the, we all know that we all are from the same fraternity, we all know that. So our main motive is that. And we have most of the data collection from here, as our students know that, right? So we have those kinds of patients inputs also. You all know about these machines. That machine must be new to you because it's been obsolete now. अभी हमारे पास सबसे पुराना machine यही है, right? And 5-action basically. It has all the currents possible. Zimmer has all the combination possible, and we have vibration therapy there. Vibration therapy machine, right? And that area where you all had that session, we have a gym area. Basically, exercise therapy is done there. Pediatric students are those are admitted in our school or outpatient also. They come there. That's a pediatric session, exercise therapy session, and a gym area. Right? We do manual therapy here. This with manual therapy here or in whichever speaking. Right? Microwave, and one more thing that I was talking about as there. This, we have compression therapy also. This one, microwave compression therapy, and we have obsolete shortwave diathermy, as everyone knows the reasons. We have just microwave diathermy here. Any question you want to ask about any machine you can. Class 1. Both. Basically, that one has 3A. 3A also because of class for 3A